Good morning. Welcome to the 119th quarterly meeting of the Advisory Commission on Childhood Vaccines. This meeting is being recorded. If you object, you may disconnect at this time. I will now turn the meeting over to the ACCV Vice Chair, Ms. Karen Kane.
Hi, good morning. How's everybody?
Hey, Karen.
Thank you.
Good morning.
Thank you, everybody, for being here. Let's see. I know we have a very busy day. I'm having a little bit of problems getting the draft book up. Let me see. I thought that was up. Okay, so I guess we're going to start this morning with the public comment on agenda items. Do we have anybody that's waiting for a public comment?
If you have a public comment, you can raise your hand in the Zoom if you're online, or if you're calling in on your telephone, you can press *9 to raise your hand and we can unmute you.
Okay, I'm guessing that's a no public comments for the morning. So let's move on to the approval of the September 2nd meeting minutes. And I'm here to approve the minutes. Does anybody second that for the September meeting?
Yes, I second that.
Okay, thank you.
All those in favor? So everyone needs to approve them. So
Aye.
we need to hear from all the other members.
This is Daniel. I agree.
This is Dana. I agree.
This is Tim Thielen. This is my first meeting.
Right.
I was not
Yeah.
at the last meeting,
Yeah.
so I'll have to abstain.
Yeah, okay, thank you. So minutes are approved.
Okay, thank you. I would like to make a motion to amend the minutes from the December 2020. I emailed everyone this morning. The minutes, the handwritten minutes for the 2020 meeting had left out a vote from the ACCV to have Dr. Mawson present, and that was out of the minutes. And so I've emailed everybody that I would like to have the minutes state exactly the conversation that was had. I don't know if I need to read that. I've not ever done this, so I'm not sure.
So Karen, this is Tamara. We haven't either, so we need to check on the processes and the procedures to basically modify minutes that have already been approved by the ACCV, and you also approve them. So we need to check about the processes and procedures because we've never had this to happen. So before it can go forward, we need to check on the processes and procedures. So this won't be able to happen until the next meeting.
Okay, and so it'll just become on the schedule of the next meeting. And I
Yes.
emailed you my edits. And I've
Yes.
been talking to Amber. Okay, fantastic. Thank you. I'd like to welcome the report from the Division of Injury Compensation Programs by Ms. Tamara Overby, Acting Director, DICP.
So before we do that, I want to welcome Mr. Tim Thielen. He's a new ACCV member, and he is the member that's representing the vaccine manufacturers. Tim, do you want to just share with us a little information about yourself?
I'm thrilled to be joining this group. I think it's important work. I've been with GlaxoSmithKline as an in-house lawyer, assistant general counsel for just a little bit more than 25 years. GlaxoSmithKline is a vaccine manufacturer. And in that time, I've worked closely at various points with our vaccine groups and from a legal perspective. So I'm happy to present the point of view of that group, but just generally as a member of the citizen of the United States and a member of sort of a concerned class of people about vaccines and making sure that vaccines are used well, and the compensation program is working well for it. I have a personal interest in it, My family is, I have 4 kids and 4 grandchildren currently, and all of them have been vaccinated variously with different products. And so these are all personal and important concerns to me as well. So anyway, glad to be part of the group. Thank you very much for the invitation to serve.
Welcome, welcome. I'm very excited to have more members. And on that note,
Karen, I'm sorry.
what is the status?
This is Annie. I think we moved a little bit quickly through the public comment, and we have someone who wants to make a public comment on the agenda items. Can we go back to that item?
Absolutely.
Okay, give me 1 second.
Can everyone hear me okay?
Yes.
I just want to thank Ms. Herzog for seeing that I have my hand up. I appreciate it. My name is Teresa Wrangham. I'm the Executive Director for the National Vaccine Information Center. Or unfamiliar with our organization helped to draft language within the 1986 Act that created the ACCV, and we represent parents with vaccine safety concerns and people who have been harmed by vaccines. My comments with regard to the agenda this morning is I'd like to say it's very encouraging to see that there's going to be a vote on a chairperson. However, I would note that there continue to be longstanding absences within this committee, and other federal advisory committees that shape vaccine policy are not suffering from those absences. Particularly noted is the lack of representation from the vaccine injury bar, or vaccine injury compensation attorneys. I believe the bar makes a recommendation every year, so I hope we see these vacancies filled. They've been unfilled for a while. With regard to other items on the agenda, I hope that the CDC will be presenting information on natural immunity and how VSafe reports will be treated and if they'll be integrated into VAERS for higher public transparency. I'm hoping that the FDA will comment on how Comirnaty is legally distinct from the experimental vaccine, and the VICP, and if HRSA would comment on the VICP's ability to handle injuries as a result of COVID-19 vaccines that are currently going to CICP. VICP is more generous, is more transparent, and I'm just wondering what their ability is and what the intention of HRSA is to put COVID vaccines within the VICP scope so that people may be generously compensated and have attorneys at their disposal more easily. Thank you for allowing me the opportunity to comment.
Thank you, Teresa. Are we, I see somebody else has a hand up, Carolyn Gamachia.
Yep.
Okay, so can we
I'm gonna
welcome?
unmute her. Mhm.
Okay, thank you. Welcome, Carolyn.
Hello, I don't know if you can hear me at
Yes.
this point, but I would like to say I will wait until the afternoon public comment section where there's going to be more time allowed, because I do see that at this point, there was only 5 minutes on the agenda, items to be able to comment. But I would like to say that within the context of this, and to allow people to make public comment just on the agenda, that there would be for future meetings more consideration than a 5-minute comment section. Because for me, I had some difficulty getting into the meeting, and I don't know about other participants, but I will wait until the 1 p.m. or the next public comment section to voice what I wanted to comment on today. Thank you.
Thank you, Ms. Gamachia. I also, so is that the last public comment for the morning?
Yes, there are no other hands raised at this point. Thank you.
Okay, so of course, as I say every time at the very beginning of the meeting, and I'm very excited to have a new commissioner on board. Is there any updates on the other parent position? And I'm obviously concerned about that position, but I'm also concerned about the lawyer for the petitioner's position. That actually has been open for a year now. Well, the parent position has been open 2 years. So I've been serving as a parent of a vaccine-injured child on this board without another parent. So I really look forward to having those two positions. Do we have any updates on that?
So Karen, this is Tamara. We're working to fill all of those positions.
Okay. Yeah, I know that. I've talked to a couple of lawyers who have put their name in a year ago or longer. And, I just feel like, obviously, as the parent, the petitioner for the attorneys is very important to have that position filled, especially for today's meeting. But okay, thank you. So I guess we should move on to pardon?
No, I was going to say, so are you ready for me to make my presentation?
I absolutely am.
Okay.
Thank you.
Okay. So Annie, can you put it up and you all advance the slides for me?
Yes, ma'am.
Okay.
Is it up showing?
It's showing, but it's showing not the full screen view for the slides. It's showing the, yeah, there we go. Okay.
Okay.
All right. So this is Tamara Overby, and I am the acting director of the Division of Injury Compensation Programs, and I will provide an update on the National Vaccine Injury Compensation Program today, specifically the HRSA activities. So next slide. So in addition to the update that I'll provide, we'll also get an update from the Department of Justice Vaccine Litigation Office, as well as getting updates from the ACCV ex officio members that are representing the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, and the Office of Infectious Diseases and HIV Policy. Next slide. So in 2021, we did actually have 2,058 claims that were filed. And so far this year, there's a typo in here. There are a total of 180 claims that are filed. So there should be 161 adults claims filed and 19 claims filed on behalf of children, for a total of 180 claims filed so far this fiscal year. And our fiscal year just started October 1st. Next slide. This slide shows a graphical depiction of the number of claims that have been filed in the Vaccine Injury Compensation Program from 2010 through fiscal year 2021. And as you can see, we did have a drastic increase in 2021, and that resulted because we had 800 claims filed in 1 month in January. And those claims were filed because, as some people may remember, there was a final rule that was issued proposing to remove shoulder injury related to vaccine administration from the vaccine injury table. So we had an influx of claims that were filed before that final rule became effective, but then that final rule was rescinded. So just for that particular month in January, we had 800 claims filed. Next slide.
Tamara, can
Yes.
I interrupt you for 1 second? I
Yes.
think I pulled up the wrong presentation. Can I correct that?
Sure, sure.
Okay, can you guys give me just 1 second? Thank you. I'm sorry, just 1 more second. Okay, I'm sorry about that. Can you see it now?
Not yet, Annie.
Not yet? Okay, I'm so sorry about that.
Okay, so we can see it now, Annie.
Let me get to the right page. We were
Okay.
on page 4, right? This one? No.
No, next page. Now the next slide.
Next page.
Okay,
Okay,
yes.
I'm so sorry
Okay.
for the delay. Thank you so
That's
much.
fine. So this slide depicts the fact that we've had the number of claims that we've had filed compared to our administrative budget, and showing that the claims filed, a percentage of claims filed have not had commensurate increases in administrative funding for the program. Next slide. This slide depicts the petitions that we have awaiting review as of November 29th. And at this point, we have 1,502 claims that are awaiting review on behalf of adults and 101 on behalf of children, for a total of 1,603. But what I'll point out here is that of the 101 that are here that are awaiting review, these petitions have not been activated by the court, so because they don't have sufficient medical records to be deemed substantially complete. So these truly are not claims that we have that are sitting waiting for review. These are claims that are sitting waiting to be completed and for the court to activate them. And then for adults, Annie, if you go back, for the adults, the same situation applies to 833 of the 1,502. 833 have not been activated by the Office of Special Masters. So again, they're waiting to be completed. So now you can go to the next slide, Annie. As far as the amount of compensation that we've paid so far this year, we paid out close to $17 million in petitioners awards and nearly $4 million for attorneys' fees and costs. As far as the number of adjudications, as of November 1st, the 69 claims have been determined compensable, 11 have been dismissed, for a total of 80 so far this fiscal year. As far as the categories of compensation, for this fiscal year so far, 34 of them have been concessions, and a concession is where HHS has conceded that the vaccine caused the injury. At this point, none have been determined compensable by a court decision, but we do have 35 that have been settled. And in cases of settlement, the government settles for various reasons. It could be that it's cheaper for the government to settle rather than go through litigation. But so far we have 35 of those claims for a total of 80 adjudications. The trust fund, the Vaccine Injury Compensation Trust Fund has close to $4.2 billion in it. And as you can see, a lot of the income is coming from excise tax revenue, interest on investments, and yeah, so that's for a total income of $365.4 million. Next slide. So the trends in the program, we have modified this to account for the end of fiscal year 2021. And so for the last 2 fiscal years, that would be fiscal year 2020 and 2021, 95% of the petitions that were filed on behalf of adults. Over 68% of the petitions filed in the last 2 fiscal years alleged the injury of shoulder injury related to vaccine administration, or SERVA. And 75% of the petitions filed in the last 2 fiscal years allege an injury from the influenza vaccine. And about 55% of the petitions filed are compensated via negotiated settlement. And currently there's a 13-month wait for petitions to be reviewed by a HRSA physician after the court activates the case. Next slide. We continue to seek nominations for all ACCV positions. We have an open and continuous accepting of nominations. So if you know of members or know of other people who are interested in serving in ACCV, please definitely have them to send their nominations, resumes, CVs to Annie Herzog, and her information is included here at accv@hrsa.gov. Next one. And that's the end of my presentation. And are there any questions?
Yeah, this is Tim Thielen. A quick question about the open positions, especially
Yes.
the open position for the vaccine injury bar member. Is there somebody who's currently in the wings for that? Because I agree that seems to be an important one to make sure that we have filled as soon as possible.
So
is there anybody, or is it still a position where we're looking for nominees?
we're always continuing to look for nominees, but there is someone that where a nomination has been sent to the secretary, and so it's in the works of bringing on someone. Yes.
I know it naturally takes some time to do the vetting and background.
Exactly. Yes.
It did in my case as well.
Yes.
So I'm glad that it's underway. Thank you.
And it's happening in this situation as well. It takes a while. Yes.
Great. Thank you.
And like I said, we always are seeking nominations because things happen. And so the more nominations that we have, the better, and the quicker we can move through the process of sending nominations forward. Any other questions?
Tamara, this is
Yes.
Karen. I have a question. How are we advertising? How are those positions being advertised to the public, letting people know that they're open? I see that it's on, the website, but many people don't even understand what the ACCV is or know about it. And so how are we reaching out to people to get them, especially parents? I know that I've talked to Christina from the bar asking about the petitioner position, but how does the ACCV advertise for this?
So it varies, Karen, by who we're trying to reach. So with regard to parents, we reach out through DOJ, reaches out to petitions attorneys to request members, to request nominations. For healthcare professionals, we reach out to professional organizations. And we also rely on you all as members too to help get the word out. And we have it on our website. So we use different mechanisms to reach out to various constituent groups to seek nominations.
Okay, thank you very much. It's nice to have the new members. That's always makes me very happy. I can't wait to have another parent on, and my position is just open for the next year. Okay, so do we have other questions? Okay, well, thank you so much. And let's move on to the report from the Department of Justice from Ms. Heather Perlman. Welcome.
Hi,
Heather.
thank you. Can you all hear me okay?
Yes, we can hear you, Heather.
Excellent, thanks. Good morning, everyone. I'm Heather Perlman. I am the Deputy Director at DOJ's Office of Vaccine Litigation. Can you move to the next slide, Annie, please? Before I begin, just a reminder that our reporting period is different from HHS's, which is why the numbers you will hear are different than what Tamara just gave. During our reporting period, which was from August 16th through November 15th of this year, there were 300 petitions filed. Of the 300, 266 involved adults and 34 involved minors. Next slide. The total petitions adjudicated during this reporting period were 266. The vast majority, 83%, 222 cases were compensated. That divides up between 96 cases in which HHS conceded liability and 126 cases not conceded by HHS. There were also 44 cases that were not compensated and were dismissed. Next slide. There were 21 cases where the petition was voluntarily withdrawn during this reporting period. Next page, sorry. Appeals, there were no decided cases at the federal circuit during the last 3 months. Next slide. There are 3 cases pending at the federal circuit, 2 which petitioner appealed and 1 which respondent appealed. Next slide. At the U.S. Court of Federal Claims, which is our first level appeal, there were 7 cases decided. 5 of the cases were affirmed, 1 was reversed, and 1 was remanded back to the special master for additional findings and processing. The U.S. Court of Federal Claims decided 1 case in an appeal by respondent, Flores versus HHS, that was affirmed in part and reversed in part. Next slide. There are 8 cases pending at the U.S. Court of Federal Claims that were appealed by petitioner. 6 involve entitlement issues, 1 damages issues, and 1 attorney's fee issues. There are also 2 cases, next slide, where respondent has appealed to the Court of Federal Claims, and those cases remain pending. Next slide. Scheduled oral arguments. Although the U.S. Court of Appeals for the Federal Circuit says none, I will say that Sanchez, which you just heard about on the previous page, has been scheduled for January 10th. And there is 1 upcoming oral argument at the U.S. Court of Federal Claims, which is Mager, which will be December 8th, 2021. Settlements. During this period, there were 122. They ranged from 11 months to 6 years in terms of how long it's taken to process these cases. The vast majority, as you will see, involve SERVA, which makes sense given that most of our cases are SERVA. And if you go forward a few slides, Annie, we get to our appendix. It is the standard appendix that we have used in the past, but it includes the glossary of terms, which is slides 23 and 24 and 25. Petition processing, the life of a claim is slide 26. Oops, sorry, I think I have the wrong numbers. The levels of appeal in Vaccine Act cases is the next slide. And then there is a flow chart for the appeals process, how that works. And that concludes my presentation. I am happy to answer any questions that anyone might have.
This is Dan Boyle. I just want to thank you for including the appendix, the glossary, and the flow charts. That was very helpful to understand the process. Appreciate it.
Great, thank you.
This is Tim Thielen. I thought so as well. One question. The reporting, I think, ends with the Department of Justice handling of the matters. There are a couple categories in which there is either a denial of claim or a withdrawn claim. Is there any data available that you track on the disposition of those that are sort of taken out of this system at all?
We do not track cases after they leave the program.
Thank you.
You're welcome.
Do we have any other questions? Okay, thank you so much. Ms. Perlman. Now we'll be moving to the update on the Immunization Safety Office and the Centers of Disease Control and Prevention vaccine activities by Mr. Jonathan Duffy. Welcome, Jonathan.
Good morning. So yeah, I'll just be presenting an update on vaccine safety activities from Immunization Safety Office. Next slide, please. So first, I'll be talking about work related to the COVID-19 vaccines. COVID-19 vaccine safety monitoring continues to be a priority for CDC's Immunization Safety Office. So just as a reminder, CDC currently has recommendations for the use of 3 different COVID-19 vaccines in the United States, which just referred to by their manufacturer names Pfizer, Moderna, and Janssen, and the full recommendations are available on the CDC website. Next slide, please. So the Advisory Committee on Immunization Practices to CDC has continued to hold additional meetings to discuss topics related to COVID-19 vaccines. As a reminder, ACIP normally meets 3 times a year, but during the COVID-19 emergency has held many additional meetings to update COVID-19 related recommendations. So since the last ACCV meeting, ACIP has met on these 4 dates specifically to discuss COVID-19 vaccines. Next slide, please. So it just, a lot of information has been presented at those meetings, and recommendations have been changing frequently as more information has become available. So I just want to kind of briefly summarize some of the important developments over the last several months. So first here, this is recommendations for an additional dose and a booster dose of COVID-19 vaccine. So ACIP has issued recommendations for an additional primary mRNA COVID vaccine dose for immunocompromised persons. So that's a 3rd dose for immunocompromised persons, and then a COVID-19 vaccine booster dose in eligible groups. And of course, the groups that are eligible, that has also been rapidly evolving as additional authorizations have come for vaccines from the FDA. So next slide, please. So this is the current recommendations for a booster dose. This is the information that was posted on the CDC website as of Monday. And so again, it's been changing over the last several months, but this is the current recommendation from CDC, is that everyone ages 18 and older should get a booster dose. And then, as you can see, that depending on the type of vaccine that the person received, there's specific information for the age groups and the timing of when a booster dose should be given. And again, this is information from the CDC website. Next slide, please. The other main development in vaccine recommendations has been recommendation for the use of the Pfizer Biotech COVID-19 vaccine in children ages 5 to 11. So this vaccine was authorized by FDA on October 29th, and CDC's ACIP committee made a recommendation on November 2nd, an interim recommendation that the vaccine should be given to children ages 5 to 11 years for the prevention of COVID. It was noted that this vaccine has high efficacy, greater than 90% against COVID in children ages 5 to 11, and that the benefits outweigh the risks for vaccination in this age group. And it was noted that vaccination is important to protect children against COVID-19 and reduce community transmission of SARS-CoV-2 virus. Next slide, please. As I said, vaccine safety monitoring for the COVID vaccines has continued, and many presentations have been provided on updates at the ACIP meetings. In addition to that, CDC has published multiple papers here just in the last few months. So I won't go through all these in detail, but I just note that there's been publications using data from multiple systems, including VAERS, the Vaccine Adverse Event Reporting System, VSD, the Vaccine Safety Data Link, and the newer system, vSafe. And so the topics that there have been reports published on include surveillance for multiple adverse events, surveillance for spontaneous abortions during pregnancy, and then safety monitoring for the additional dose. Next slide, please. There's also been publications on reactogenicity, which is local and systemic adverse effects following the mRNA vaccines. There's been a publication on just general safety monitoring of the overall experiences during the first 6 months of the vaccination program. And then this last one was a report on examining non-COVID mortality risk following vaccination. Next slide, please. So COVID-19 vaccinations, just some data from the CDC COVID data tracker on where things stand as of November 28th in the United States. There were over 196 million people reported as fully vaccinated and over 37 million people who had received a booster dose as of that date. Next slide, please. So during this time, the ACIP has also addressed topics related to other vaccines other than COVID. So I just want to again briefly summarize some of the other vaccine topics that have been discussed by ACIP over the last 3 months. So the first one relates to vaccine for tick-borne encephalitis. So it was noted that the FDA approved a vaccine manufactured by Pfizer on August 13th. And so the ACIP has a tick-borne encephalitis work group, which had been formed in anticipation of this in 2020 to review the use of TBE vaccines in U.S. adults and children traveling abroad, as this is a disease that is endemic in other parts of the world rather than in the United States. So just the future plan is that ACIP will plan to vote on vaccine recommendations for this travel vaccine next year. Next slide, please. So there was a discussion of Zoster vaccines. And so ACIP voted for a new recommendation that says 2 doses of recombinant Zoster vaccine are recommended for the prevention of herpes zoster and its complications in adults 19 years of age and older who will be immunodeficient or immunosuppressed due to disease or therapy. So again, this is a new recommendation for adults with immunosuppressive conditions. Next slide, please. ACIP also voted for new recommendations for pneumococcal vaccines. So again, these are new pneumococcal vaccines that have been recently licensed by FDA, and these recommendations are for adults. So there's 2 distinct recommendations. One is an age-based recommendation for adults 65 years and age of older who have not previously received a pneumococcal vaccine. And the recommendation is for the use of one of the 2 new vaccines known as PCV20 or PCV15. And the second recommendation is for adults aged 19 years of age and older with certain underlying medical conditions or other risk factors for pneumococcal disease who have not previously been vaccinated. So again, there's recommendation for either PCV20 or PCV15 for these adults. Next slide, please. For influenza vaccines, there was information presented to ACIP. So these are not new recommendations. This was just informational presentations. One was on a safety study of safety and immunogenicity of the co-administration of Fluzone high-dose quadrivalent influenza vaccine administered at the same time as a 3rd dose of the Moderna mRNA vaccine. And so, this basically showed that reassuring findings for both immunogenicity and safety for the co-administration of these 2 vaccines. And the second presentation was on the new availability of a cell culture-based inactivated influenza vaccine, which FDA had expanded the approved age range to now include people ages 6 months and older. And so it was noted that there are now 5 inactivated influenza vaccines that are approved for the age group of 6 months and older. And so this information was just being updated. Next slide, please. So there was also discussion of hepatitis B vaccines. And so ACIP voted for new recommendations. So the ACIP recommends the following group should receive hepatitis B vaccine. So this is adults 19 through 59 years of age. And then adults 60 years and older with risk factors should also receive a hepatitis B vaccine. And then the ACIP recommends the following groups may receive hepatitis B vaccine. And that was for adults 60 years and older without known risk factors. So again, these are new vaccine recommendations for adults. Next slide, please. So there was also a session on orthopoxy viruses. Just as a reminder, this includes this is a genus of virus that includes human pathogens such as smallpox and monkeypox and various other species that can also infect humans. And so ACIP voted for 5 new recommendations for the use of the brand name Jynneos vaccine for persons who are at risk for occupational exposure to these viruses. So just, a very high level summary of these detailed recommendations. These are recommendations for laboratory personnel or healthcare personnel who may be working with these viruses or with the smallpox vaccine or people who may be infected with these. So this is recommendation for certain occupational risk groups. Next slide, please. So in a similar situation, there was discussion of Ebola vaccine. So ACIP voted for 2 new recommendations for the use of the Ebola vaccine. And again, this is for people with certain occupational risk factors. So this was for pre-exposure vaccination for healthcare personnel involved in the care and transport of suspected or confirmed Ebola virus disease patients at special pathogen treatment centers. These are designated centers in the United States that are, prepared to treat Ebola patients when needed. And then the second recommendation is for pre-exposure vaccination with Ebola vaccine for laboratory workers as part of the laboratory response network and facilities, that basically supporter would be handling specimens that potentially could contain Ebola virus in the United States. So again, these are sort of occupational specific recommendations for the use of Ebola vaccine in adults. Next slide. So just as a reminder, recommendations voted on by the ACIP, are then become final when they're approved by the CDC director and then published in the MMWR. So those are the summary of what was voted on at the meetings, and then those recommendations will be finalized when published. So that concludes my update. Thank you.
Thank you, Mr. Duffy. Does anybody have any questions?
This is Dana Deshawn. I just had a question. Was there any talk about the booster or any recommendations they would do for those under age 18 for the COVID-19 vaccine?
I don't know if that's been discussed specifically. I mean, I think that will be a topic for future consideration. And it really, any discussion about ACIP recommendations is really contingent on what uses of the vaccine are authorized by FDA. So I think, any news on that will come first from whether FDA would authorize a booster dose in persons under 18, outside the current authorizations.
I have a question. This is Tim Thielen. Dr. Duffy, thanks very much for that. One question, I think in the previous minutes that I was looking through, I'm new to the commission. I noticed that there was a question about whether or not there was some information that there might be a study about cross use of different vaccines in COVID for a booster. So you might have a full dose, 2 doses of say Pfizer, and then cross use of Moderna for boosting. Has there been any studies on that, or is there any plan to do that sponsored by the CDC? As shown on that slide and available on the CDC website, so that's referred to as heterologous boosting. So that's when a person receives a different product than they had received for their initial vaccine dose or series. And so that is currently recommended. I think, some information about that has been presented at the ACIP meeting. So I don't know all the details, but I do believe there had been, some studies reviewed for that. And of course, as part of our safety surveillance, that is, something CDC will also be looking at is, what experiences people are having in receiving the different possible combinations of different vaccine products. Thank you.
And hi, this is Claire from NIH. We supported a phase 1 trial looking at heterologous booster doses, and I'll be talking a little bit about that study during my presentation today.
It was probably your section that I saw it in before. Thank you very much.
Hi, this is Karen. Are there any other questions? Okay, I have a couple questions, of course. Mr. Duffy, are all the vaccines available to children as recommended by the AC still experimental?
Well, so the Pfizer Biotech vaccine is the one that's recommended for people less than 18 years of age. And so as I understand it, the FDA has approved that vaccine. Believe I'm going off memory here. I believe for ages 16 above. And so I believe the vaccine for people outside that age group is still being used under an emergency use authorization from FDA.
So when you say it's approved, does that mean it's a licensed vaccine in the US then?
Yeah, the Pfizer vaccine under brand name Comirnaty has been licensed by the FDA, but again, I would direct questions about licensure of vaccines to the FDA.
Okay, and then I have a few questions for you today. Will they be integrating the VSafe into the VAERS for transparency? It seems to me that there's different places to report, and I think most people, there's always that question from the Harvard Pilgrim study, how many people are reporting injury, but is there any reason that the VAERS and the VSafe are different, and will you guys combine that? Will that be combined for basic transparency?
Yeah, so thank you for the question. So I think, so just to try and lay this out clearly. So yeah, VAERS is a system that existed prior to the pandemic and had established, mechanisms for data posting and public data use. VSafe was a new system that was created after the pandemic began, specifically to collect information related to people's experience with COVID-19 vaccines. So that was a new system that was built, separately and independently from VAERS. As far as, the actual mechanism of which, people submit data and how that data is stored. So, I think it's just to be clear, those are really two separate systems. And I think as we've discussed at previous meetings that, CDC uses the information that people submit to VSafe to help facilitate or prompt reporting of adverse events to VAERS. So in that sense, it does, sort of stimulate or prompt people to report additional information about their experiences to VAERS. But as far as, whether the actual data that is submitted to VSafe, if or when, that would or could be made publicly available, I don't currently have an answer to that at this moment.
So is the VSafe data open to the public, just like VAERS? Or how would a person access the VSafe reports?
Yeah, so at the moment, to my knowledge, there's no public access mechanism for the VSafe data.
Oh, okay. And I don't know if you're the right person to ask this question, but it's on my mind, certainly. Will the COVID vaccines be part of the vaccine injury compensation program? Is there any talk about that, or who would I ask that question to?
So, Karen, it's Tamara, and I would be the person that answers that question. And currently, no COVID vaccines meet the requirements to be included in the vaccine injury compensation program. For primarily at this point, it would have to be an excise tax would have to be imposed, and that hasn't been done yet. And Congress would have to impose that excise tax.
And thank you for that. Is there any talk about that? Is there any plans? I mean, I would guess that it seems like everyone would be at least thinking about it. I mean, how do you find the update? Will we just be continuing to talk about this at the meetings, or how does one get more information on what the plan is, or is there a plan?
So we don't know when Congress would impose an excise tax. I don't have an answer for you, Karen, because we don't know when Congress would do it. We can't lobby Congress. We don't lobby Congress to enact legislation. So that's up to Congress to decide when they want to impose an excise tax.
Okay, thank you. Does the administration support an excise tax to add these vaccines to the VICP?
So Karen, I cannot speak for what's happening at the department level.
Okay, thank you. Thank you. Mr. Duffy, I have a couple of questions for you. I've been just reread the white paper, and I was just wondering, because the white paper had just has the study that was outlined in the white paper been carried out? And if not, why? And when specifically will it be done? The white paper was written in 2015, and the white paper suggested that more studies be carried out. And I was just wondering if you could tell me if that had been done and I've just not read it, or what's the status on that?
Okay, yeah, so just so other people understand the question, this white paper being referred to is a paper that was written regarding the vaccine safety data link. So studying the safety of the childhood immunization schedule in the vaccine safety data link. And so that was a paper published in 2013 that outlined sort of a information on how the VSD could be used to study the safety of the childhood immunization schedule. And so, what was outlined in that paper was, well, several different things, but I think, to get at your question, it sort of outlined not just a single study, but a list of proposed health outcomes to look at. So that paper included 20 different health outcomes, rather than, just looking at some sort of a single study. So it was really an outline for doing more than one study. And so I think, as presented to this group about a year ago, or sometime in 2020, there has been some progress made on that. And so since 2013, as I previously presented, there's been, VSD has published 13 studies related to the immunization schedule. And to my knowledge, I think at least 4 of the health outcomes that were addressed in the white paper, there's already been studies published on. And so there are additional studies ongoing, but I can't tell you at the moment exactly how many or when the expected publication date would be of those studies. Because I think, as a lot of people are aware, sort of the actual publication process can, take some months in time. So, it's hard to, to estimate exactly, how long it takes to sort of, complete a publication that would be, available, if you consider, the actual publication as sort of the completion of a research project.
Okay, thank you. On that note, I have a couple other questions for you. What researchers outside the CDC and HMOs have been granted access to the VSD? Do you know? Can you tell me that?
Well, so the vaccine safety data link, I think there's, as described on the CDC website, there's 2 main data sharing mechanisms or data sharing possibilities. So one is requesting access to data sets through the NCHS. And so I don't know the specific number of people that have requested access to that data. I know that, some requests are submitted at different times, but I don't know the exact number of how many people requested data or how many people have actually followed through with receiving the data. And then, there's a separate mechanism where, people can try to contact or work with one of the VSD site investigators to propose new study ideas. And again, I'm not aware at the moment what number of people may have attempted to use that mechanism.
Thank you. And can you email me those studies that you were just the link so I can look at those studies that you're referring to about the white paper? So obviously you can't today. I mean, whenever you can after the meeting, that would be appreciated. And then I have.
So Karen, this is Tamara. He presented, John Duffy presented at the December 2020 meeting, and those studies are listed there and they're on our website. So, because you were at that meeting and he presented those studies at that meeting, and those studies are listed in the presentation from the December 2020 meeting. So they're on the website.
Okay, thank you. Appreciate that. How many unvaccinated controls are contained in the VSD, and how are they identified? Example, by a designation such as a religious exemption on file, as such, so controls are absolutely, that would be the way to do a control group. And so my question, are there unvaccinated controls that are identified with the VSD?
Yeah, so So in one of the papers that was published, so there was a study that was published by VST investigators in 2013 that was to basically the objective of that was to assess or examine patterns and trends of under vaccination in children between ages 2 and 24 months of age. And so under vaccination includes children that haven't received any of the recommended vaccines, and also children that receive some of the recommended vaccines and not others, and then people who receive recommended vaccines but on schedules that are delayed compared to the ACIP recommended schedule. So yeah, that was one of the earlier studies related to studying the safety of the vaccination schedule that was published by VSD. And so at that time, that study included over 300,000 children. And they found that, about 48% were under vaccinated for at least one day before age 24 months. And then looking at specific vaccination patterns, they found about 2.8% of the children in that cohort were on schedules that appeared to be specific non-standard schedules. That would be like schedules that aren't like the ACIP recommended schedule, but may reflect, other recognized patterns. And then there was approximately 1% of children who had no record of receiving any doses of 8 vaccines that are recommended before 2 years of age. So about 1% of children had no record. And then, so there's been some follow-up work on that topic too, because again, this is looking at health records. So the question is whether the health records accurately represent a child's true vaccination status. So there'd been some additional work on whether the health records and parent report of childhood vaccination agree. And, there had been a fairly good agreement between those two, sources of information on childhood vaccination. So I think, yeah, I mean, the bottom line is that, the vaccine safety data link uses people's, health insurance medical records and links that to people's immunization history. So that's the primary source of information on whether a person has received a specific vaccine or not. And then as to reasons why, people don't receive those vaccines, that's not always reflected in the medical record.
Thank you so much. And so that basically there like a column that religious exemption, because that's becoming, well, now there's like a medical exemption, but that typically means that there's another underlying condition. But in the VSD, do you know if there's such a area that says, a religious exemption, because, that would be very clear that that person would not be receiving any vaccines to use the VSD to run studies?
Well, so the vaccine safety data link, again, I mean, it relies on medical administration data. So it uses sort of standard code sets such as what's commonly known as ICD-10, the International Classification of Diseases. So, I mean, these are standardized code sets that are used, for either administrative or billing purposes. So in that regard, it's just important to keep in mind that, so that, the vaccine safety data link is sort of using data that is collected for non-research purposes. And so, the data that's available is the data that is collected by health plans for, the administration of healthcare. And so, to my knowledge, the ICD-10 code set includes a code for sort of, the parent decided not to have a child receive a vaccine, but I'm not aware that that there's a specific code for religious exemption or the reason why a parent would choose not to have a child receive a vaccine. So, yeah, so I don't believe, or to my knowledge, I don't believe that a religious exemption is an information that is commonly coded or captured in a healthcare system such as VSD.
Thank you. You have a lot of information. I appreciate that. 2 more questions. Has the CDC assembled in one convenient place data on the background or baseline rates of acute and chronic conditions that could be associated with vaccines among the unvaccinated controls for purposes of comparing the baseline data to rates of acute and chronic injury for children exposed to the schedule? Do you know that?
Well, so yeah, I mean, that's a very broad topic because, obviously the number of conditions that can exist, as represented by, standardized code sets such as International Classification of Diseases runs to thousands of different health conditions and diseases. So, So yeah, broadly speaking, I mean, I think obviously, CDC, does surveillance and tracks the incidence and prevalence of a lot of different diseases outside of the vaccine safety program. So just understanding the rates of disease in the population. So specific to vaccine safety, again, it depends on the system you're looking at. Certainly within the vaccine safety data link, it depends on, the system is used to do specific studies. So within the context of a specific study, you would have to identify the disease of interest. And then depending on the study design, there'd be determinations on how to analyze that. So if you're asking, is there just like some sort of data source that just, lists the incidence or the prevalence of, every different possible disease or outcome that can occur? I don't think that's a very broad thing. I don't think that exists in a single, data set or publication. Because that's a very broad question.
I appreciate that. Okay, and then do you know how many kids in total are unvaccinated in the controls? I mean, there's a way to look at that are totally unvaccinated.
So if you're referring specifically to the vaccine safety data link, that is a dynamic population in the sense that it's continually updating data as people enroll in these participating health plans. So, there's constantly new people joining and new children being born. The specific number is going to be changing, on a weekly basis probably. And so as I referred to earlier, that earlier publication was a study that looked at that specifically. So like I said, they found that, among people who are enrolled in the VSD participating health plans, about 1% of the children before 2 years of age had no record of receiving any of 8 recommended vaccines. So, each, that publication is a snapshot in time. And so, the specific number is dynamic or variable. It's probably, changing from time to time. So, yeah, I mean, that's something that has been looked at before and could be looked at again.
Thank you so much. So you'll be very happy to know this is my last question. So there's a lot of attention right now on the section 27B that requires the secretary to establish a task force on safer childhood vaccines in consultation with the ACCV. I was wondering if that task force is still intact. They were supposed to do some reporting since 1998, and is that task force intact? And if not, why? Because the ACCV was actually supposed to work together with that task force, but I never heard of it since I've been on the program, and I was just curious to what you could tell me about that.
Well, that is a topic about which I am not personally knowledgeable. And so if it, relates to the Secretary of HHS or something, I think probably, someone else in HHS would probably be better to address that question.
Okay. Fantastic. Thank you so much. I appreciate that. That's a lot of information.
Welcome.
Okay, so are there any other questions? Since I've taken up a lot of time, but it's all important information. Are we ready to move on to the update of the National Institute of Allergy and Infectious Diseases, National Institutes of Health vaccine activities with Miss Claire Schuster? Welcome, Miss Schuster.
Hi, Karen, I'm sorry, this is Annie. If I could interrupt for just 1 second, I just wanted to confirm that Dr. Holloway is now on the line.
Okay.
Dr. Holloway, oh.
I'm on the line.
Okay, thank you so much. Okay, I will pull up Claire's presentation.
Great, thanks, Annie. Thanks, Karen.
Thank you, and welcome, Dr. Holloway.
Great, thank you, Annie. Hi, I'm Claire Schuster, and today I will be presenting the update for the National Institutes of Health. Next slide, please. The NIH Researching COVID to Enhance Recovery Initiative, or RECOVER, seeks to learn why some people have prolonged symptoms referred to long COVID, or develop newer returning symptoms after the acute phase of SARS-CoV-2 infection. NIH has awarded nearly $470 million to build a national study population of diverse research volunteers and support large-scale studies on the long-term effects of COVID-19. The NIH RECOVER initiative made an award to New York University Langone Health, which will make subawards to more than 100 researchers at more than 30 institutions and serves as the RECOVER Clinical Science Core. This award supports new studies of COVID-19 survivors and leverages existing large cohort studies to expand their research focus. The studies conducted through RECOVER are expected to provide insight into many important questions, including the incidence and prevalence of long-term effects of SARS-CoV-2 infection, the range of symptoms, underlying causes, risk factors, outcomes, and potential strategies for treatment and prevention. Next slide, please. As part of the RECOVER initiative, women infected with SARS-CoV-2 during pregnancy will be followed for 4 years to assess potential long-term effects of COVID-19. The study will also follow their offspring for any potential long-term effects. Participants will be recruited from an earlier study by the Maternal Fetal Medicine Units Network, a 36-site research collaboration supported by NIH's Eunice Kennedy Shriver National Institute of Child Health and Human Development. The research teams will assess patient symptoms periodically over 4 years and evaluate their offspring for neurologic symptoms and cardiovascular conditions. The researchers seek to understand what proportion of patients with COVID-19 in pregnancy are at risk for long COVID, whether the severity of COVID-19 in pregnancy influences the likelihood of developing long COVID, and how the proportion of patients who develop post-acute sequelae of SARS-CoV-2 infection, or PASC, after COVID-19 in pregnancy compares to that of non-pregnant women who develop PASC. Next slide, please. Also part of RECOVER, a long-term study looking at the impact of COVID-19 on children has enrolled its first participant at NIH's Clinical Center in Bethesda, Maryland. Children's National Hospital in Washington, D.C. will also enroll participants. The study, which is supported by NIAID, will track up to 1,000 children and young adults who have previously tested positive for COVID-19 and evaluate the impact of COVID-19 on their physical and mental health over 3 years. The study is expected to yield a detailed picture of COVID-19's effects on the overall health of children, their development and immune responses to infection, and their overall quality of life in the years following infection. Next slide, please. Now I'd like to highlight an NIH website focused on COVID-19, including news related to COVID-19 in children. One article discusses how researchers have expanded COVID-19 vaccine studies to include children and ways in which the pediatric clinical trials differ from those for adults. One crucial difference involves evaluating the dose for children in different age groups to find the appropriate dose. In these pediatric trials, researchers measure the immune response to the vaccine and see how it compares to antibody levels and immune activity that protects adults and teens. The researchers also track side effects to make sure they are no worse than what adolescent or adult participants have reported. For more information, please see the link at the bottom of this slide, covid19.nih.gov. Next slide, please. In September, NIAID announced that it had awarded approximately $36.3 million to 3 academic institutions to conduct research to develop vaccines to protect against multiple types of coronaviruses and viral variants. These awards were made under the Emergency Awards Notice of Special Interest on Pan-Coronavirus Vaccine Development Program projects. A key goal of the initiative is to develop multivalent vaccine platforms that provide broad protective immunity to multiple coronavirus strains, as well as strategies suitable for use in vulnerable populations. The initiative also aims to understand vaccine-induced responses and efficacy related to a person's age or sex. Additional awards are expected in fiscal year 2022. Next slide, please. In October, preliminary findings were announced for an NIAID-supported phase 1/2 trial evaluating homologous and heterologous booster vaccinations in participants who had previously received an EUA COVID-19 vaccine regimen. Homologous means that participants were boosted with the same vaccine that they received in their primary series. And as Dr. Duffy mentioned earlier, heterologous means they received a different vaccine as their booster dose. Boosters were administered at least 12 weeks since the participant's last vaccine dose. Each of the 3 vaccines, that is COVID-19 vaccines from Moderna, Pfizer, BioNTech, and Janssen, effectively produced an immune response when used as a booster dose, regardless of which COVID-19 EUA vaccine regimen the participant had received originally. Heterologous vaccines elicited similar or higher serologic responses as compared to the respective homologous booster response. No safety concerns were identified in any of the combinations. Reactogenicity was similar to that reported for the primary COVID-19 vaccine regimen. Injection site pain, malaise, headache, and myalgia occurred in more than half of the participants. The study uses an adaptive trial design, which means that arms may be added in the future. Next slide, please. I'd like to take a minute to share this slide showing neutralizing antibody titer levels in the study. Across the top, you'll see the 3 different primary vaccination series, Janssen, Moderna, and Pfizer BioNTech. The first row shows data for the Moderna boost. The middle row is for Janssen, and the bottom row is the Pfizer boost. It's a little small in the slide, but you'll see that across all the different combinations, you'll see how antibody levels increase substantially from day 1 before the boost to day 15 post-boost. For additional details, please see the preprint posted on medRxiv on October 15th. And next slide, please. That concludes my talk, and thank you very much for your time.
Thank you, Ms. Schuster. Does anybody have any questions?
This is Dan Boyle. Thanks so much for that report on the recover. It's really good to hear about that and see the scope of it and the concern, for the recovery and the tracking of people with the long-term COVID, including pregnant women and their offspring too. And it just occurred to me as in the presentation that this is a kind of a model for what I believe we need to look at for vaccine injuries. And I don't want to get into the discussion of the scope of the research that's needed because it's a large area that we're talking about. But in terms of just thinking about a model for tracking persons that have been injured, whether self-reported or confirmed, or even through the vaccine injury program, that have been identified with confirmed cases, so to speak. However, I don't want to get into all the details. But anyway, the model, to think about a model for looking at a big picture of those that are injured and finding them and tracking them. So I just wanted to make that comment, and thanks for your presentation.
Thank you for your comment.
Does anybody else have any comments or questions? Okay, then
This
we
is-
will
this
move
is-
on.
Sorry, real quick. This is Tim Thielen. Just one quick question. In the studies that are following people who have had COVID, you mentioned 2 or 3 of them, which look like they're pretty robust. Is there going to be any reported data about whether the people who have had COVID are reinfected? So the survivors of COVID are reinfected. It seems to me that there is some data available about the so-called natural immunity issue, but we don't have a lot that's being developed in the United States. But these studies provide opportunities for some reporting of information around those. Do you know if that's a goal or an endpoint in any of them?
Yeah, that's a really important question. I don't know specifically for the Recover studies, but I can look into it and get back to you.
Thanks so much.
Thank you. Okay, so we're going to move forward to the update on the Center for Biologics Evaluation and Research, Food and Drug Administration vaccine activities by Dr. Jay Slater. Welcome, Dr. Slater.
Hi. Let me see if I'm sharing my right screen. Yes. Can you see my slides? Anyone?
I don't see any slides.
No.
Okay, I think that's because I shared the wrong screen. Hold on, let's stop that. Let's try again. Okay, now.
Yes.
Yes.
Great.
Yes.
And now I'm going to put it in presentation mode, and hopefully we'll have achieved perfection, right? Great. Can you see my slide in presentation mode?
Yes.
Great. Okay.
Yes, yes.
All right. Thank you. I'm Jay Slater. I'm actually the director of the Division of Bacterial, Parasitic, and Allergenic Products within the Office of Vaccines. And I'm happy to update you on the last 3 months of activity in OVRR. And much of this is going to sound like a duplication of what you heard just a few short minutes ago from Dr. Duffy, but I hope you'll understand and bear with me. Most relevant for an advisory committee on childhood vaccines is the recent action on October 29th, in which FDA authorized the use of the Pfizer BioNTech COVID-19 vaccine in children 5 through 11 years of age. For this group, the Pfizer BioNTech COVID-19 vaccine is supplied in multiple dose vials with orange caps to distinguish it from the adult dose because it is a different formulation. And the labels have orange borders, and it's administered intramuscularly as a primary series of 2 doses, each 0.2 mLs in volume, 3 weeks apart. As always, there's a fact sheet for healthcare providers that provides much useful practical information for the people administering the vaccine, and there's a fact sheet for recipients and caregivers as well. This authorization was discussed and supported at the Vaccines and Related Biological Products Advisory Committee meeting on October 26th. Rolling back now to September, we'll have a few slides dealing with authorizations of booster administration. We had an advisory committee meeting on September 17th that discussed this, and on September 22nd, the FDA amended the emergency use authorization, again, for the Pfizer BioNTech COVID-19 vaccine to allow the use of a single booster dose to be administered at least 6 months after the completion of the primary series to very specific groups of individuals. And you're all aware that the news has gone very quickly since September 22nd, but I'll just go through the history for you. Those groups were adults 65 years of age and older, adults 18 to 64 who were considered at high risk of severe COVID-19, and adults 64 years of age who had frequent institutional or occupational exposure to the virus that put them at risk of getting severe complications of COVID-19. On October 20th, 2021, the FDA amended the EUAs of COVID-19 vaccines to allow for additional use of single booster injections. First of all, for the use of a single booster shot of Moderna COVID-19 vaccine to be administered at least 6 months after the completion of the primary series, essentially to the same groups that I detailed in the previous slide. In addition, they authorized the use of a single booster dose of the Janssen COVID-19 vaccine that could be administered at least 2 months after completion of that dose in individuals 18 and older, and supported the use of, as Ms. Schuster explained, heterologous booster dosing for eligible individuals following the completion of their primary vaccination with a different available COVID-19 vaccine. And at the same time, the FDA clarified its previous statement about the Pfizer BioNTech vaccine and its use. And this was discussed at great length in 2 days of advisory committee meetings on October 14th and 15th. And then the FDA expanded the eligibility for use of a single booster on November 19th, amending the EUA for both the Moderna and the Pfizer BioNTech COVID-19 vaccines, authorizing the use of a single booster dose for all individuals 18 years and older after the completion of the primary series, and amended the EUA for the Janssen COVID-19 vaccine, authorizing the use of a single booster dose for all individuals 18 and older after the completion of the primary dose of an approved or authorized vaccine. That completes my presentation on the COVID-19 vaccines. In going back over our last quarterly report, I noticed that we had not previously reported one of the approvals that occurred in the prior quarter in July 2021. Vaxnuvance is a pneumococcal conjugate vaccine. It is 15 valent, covers these serotypes, and it was approved for use in adults 18 years and older for the prevention of invasive disease caused by strep pneumoniae, and this is manufactured by Merck. I apologize, this is a slide that did not appear in the set that I sent to Ms. Herzog a few days ago because it wasn't true a few days ago, but on November 30th, FDA approved a new recombinant hepatitis B vaccine called Prehevbrio, manufactured by VBI Vaccines, indicated for the prevention of hepatitis B disease in adults 18 years of age and older. And that is expected to be marketed in the United States in the first or second quarter of 2022. FDA maintains a website dedicated to its COVID-19 activities, including pandemic responses, activities pertaining to vaccines, testing, therapeutics, and devices. It's frequently updated, and I included here for your information. I want to thank you for listening to the presentation, and I'll be happy to take any questions.
Thank you, Dr. Slater. Do we have any questions? Okay, I have just two questions. Can a child get a Pfizer vaccine in the United States with a common guarantee label or just the EUA label?
So as you know, the Pfizer BioNTech vaccine is licensed. It has a biologics license that includes usage in people 16 years of age and older. So individuals who are 16 and 17 years of age can be given the Pfizer BioNTech vaccine under its license. Children who have not yet reached the age of 16, however, will get it under emergency use authorization.
Okay, thank you so much. I just have one more question. What does the approval letter mean when it says same formulation but legally distinct?
The approval letter for the Pfizer BioNTech vaccine?
Yes.
Yeah, I'm gonna have to get back to you about that.
Okay.
That's an excellent question. I will be happy to follow up on that.
Thank you so much.
Will that be public knowledge? Because I'm curious about that as well.
Well, I think the way for it to be public knowledge would be for it to discuss it at the next meeting in 3 months. So perhaps I can promise to answer the question in time for that meeting, and then we can I can be sure to clarify that for you.
Thank you.
Is that Ms. Kane, is that a good answer?
That's a great answer. Thank you. Appreciate it.
I hope I can make good on it. I will try.
Karen, this is Dana. Can you repeat your question again?
The first one or the second one?
The one that he's getting back to you on.
Apparently, it says in the approval letter for the Pfizer BioNTech vaccine, a phrase that says same formulation but legally distinct. Is that what I'm looking for?
Yes.
And if that in fact is in the approval letter, then I am going to track that down and find out what it means.
Awesome. Thank you. I appreciate you.
Okay.
Do we have any other questions for Mr. Dade or Mr. Slater? Sorry. Okay. So we will be moving on to the Office of Infectious Disease and HIV/AIDS Policy with Mr. Sean Dade. Welcome, Mr. Dade.
Thank you. Appreciate it. Okay, thank you. Okay, good morning, everybody. My name is Sean Dade, and I'm a public health advisor in the Vaccine Division for the Office of Infectious Disease and HIV/AIDS Policy under the Office of the Assistant Secretary of Health. Today, I'm going to share with you the latest updates within OIDP as it relates to our vaccine portfolio. Next slide. I wanted to start off by first providing an update on the National Vaccine Advisory Committee. This federal advisory committee convenes 15 members 3 to 4 times a year and recommends ways to achieve optimal prevention of human infectious diseases through vaccine development and provides direction to prevent adverse reactions to vaccines. This advice is presented to the Assistant Secretary for Health, who serves as the Director of the National Vaccine Program on matters related to program responsibilities. Since the last ACCV meeting, NVAC has met once in September to discuss vaccine safety and innovation. During day 1 of the meeting, we heard an enlightening presentation by the Countermeasure Acceleration Group, formerly known as Operation Warp Speed, about lessons learned in the field regarding vaccine development, manufacturing, and distribution of COVID-19 vaccines. There was also presentations on COVID-19 safety data and how to effectively tailor this data to increase confidence in the safe use of vaccines. Day 2 of the meeting was focused on vaccine innovation. The meeting kicked off with a discussion of how an immune response directly interrelates to protection. This led to a fascinating discussion about the future of mRNA vaccines for widespread use. The meeting concluded with the latest CDC flu recommendations for the 2021-2022 season, and we also heard an update from the Vaccine Confidence Subcommittee panel. Upcoming NVAC meetings for the next calendar year have already been scheduled. NVAC will convene on February 10th to the 11th, June 15th to the 16th, and the last meeting will occur on September 22nd to the 23rd. These meetings are open to the public. Archived meetings can be found on HHS's YouTube channel, and you can also view panel discussion videos and read recommendation reports at hhs.gov/vaccines/NVAC. Next slide, please. The vaccine division is currently in the process of implementing the 5-year vaccine plan, which was created in January of 2021. This plan and the activities within the National Vaccine Implementation Plan are needed to sustain and renew progress, address persistent and newly identified gaps, and to proactively respond to the changing vaccine landscape. To ensure the goals, objectives, and strategies and indicators within the plan are met by 2025, the vaccine division is currently in the process of engaging the Federal Interagency Vaccine Work Group, who serves as the steering committee who guide the implementation of the National Vaccine Plan. Since the plan was released in January of 2021, program staff have been engaging and strengthening the partnership between the IVWG and OIDP. To support this initiative, we have convened a meeting with the IVWG on September 21st to discuss frequency of meetings, roles and responsibilities, and how to properly fill out the data collection tool to ensure all activities being conducted in the federal vaccine system are captured within the National Implementation Plan. We have received the data collection tools back from all the IVWG members and are currently in the process of analyzing the data to identify gaps within the National Vaccine Plan. We are currently in the process of drafting the Federal Vaccine Implementation Plan and will request public comment within the Federal Register, hopefully sometime in January, with a tentative release date scheduled for February or March. Next slide. I'm excited to announce 2 community vaccine grants within the Office of the Assistant Secretary of Health. The goal of these grants is to increase vaccine uptake by working with local communities to increase vaccine confidence and access to routinely recommended vaccines. Vaccine confidence and access ties directly into Goal 3 and 4 of the National Vaccine Plan. The Promoting Vaccine Confidence in Local Communities through Partnership with Regional Health Offices is a cooperative agreement that started September 30th. 6 organizations were awarded funding for the next 3 years to increase vaccine confidence within their local communities. To accomplish this task, selected awardees will work with an underserved low vaccine uptake community to implement an evidence-based intervention strategy to erode vaccine hesitancy while increasing vaccine confidence in products, providers, and policy. At the conclusion of the project, the goal is for these interventions to be shared and replicated in communities throughout the nation who are facing similar issues as it relates to vaccine confidence. OIDP held a kickoff meeting on November 12th to discuss roles and responsibilities and will continue to monitor and engage awardees throughout the project period to ensure identified project objectives and deliverables are met. The second grant opportunity I would like to share with you today is an innovative approach to enhancing the immunization cultures in OBGYN care. This is a joint partnership between OIDP and the Office of Women's Health. The goal of this project is to promote and strengthen immunization culture within OBGYN offices, family practices, and birthing classes. There is currently a rolling recruitment for clinical practices and childbirth educators. These vaccine messengers will be provided with an assortment of education materials to increase awareness for the need of recommended routine vaccines. This includes the distribution of provider and parent toolkits along with recorded webinars. Next slide. I wanted to speak briefly about the importance of getting children, teens, and adults caught up on routinely recommended vaccines, which were sorely missed due to the COVID-19 pandemic. Due to the government shutdown caused by the COVID-19 pandemic, many children and teens missed their wellness visits, which included receiving their immunizations. To bring awareness to routinely recommended vaccines missed during the pandemic, HHS supports the Immunization Action Coalition Call to Action letter on the importance of adult vaccinations. OIDP is also in support and actively promotes co-administration of the influenza vaccine and other routine recommended vaccines to ensure no missed opportunities to vaccinate as families continue to get caught up on their vaccinations. OIDP is using the cooperative agreements discussed during the previous slide to increase and heighten confidence in vaccines so more children, teens, and adults can get caught up on routinely recommended vaccines. Next slide. To bring awareness to the importance of receiving the flu vaccine and other routinely recommended vaccines, the Vaccine Division is working closely with the Communication Division within OIDP to promote the importance of vaccinations. Getting recommended vaccines is especially important since in-person learning has resumed and more adults are returning to the workplace. To promote flu vaccinations through the 2021-2022 flu season, the OIDP communication team has developed toolkits specifically targeting ethnic populations such as African Americans and Latin communities to address vaccine disparities and equity. These toolkits have tailored messaging, talking points for providers, and social media messaging. We also are still promoting our Catch Up to Get Ahead toolkit, which contains information on how to increase access to vaccinations, coordinate communication, and how to utilize policy to reduce barriers to obtain delayed vaccinations. Next slide, please. In addition to the work that I have discussed in the previous slides, the Vaccine Division also works with various federal and non-federal partners to provide strategic leadership and management while encouraging collaboration, coordination, and innovation to reduce the burden of infectious diseases. We are currently working with the Office of Refugee Resettlement to gather information on COVID-19 vaccine delivery at 200 unaccompanied programs. This informational survey will allow us to better understand what barriers these providers are facing when enrolling as COVID-19 and vaccine for children providers to administer vaccines on site at their facility. Dr. David Kim, who is the director of the Vaccine Division, serves as the ex officio a member of 2 federal advisory committees, which includes FDA's Vaccines and Related Biological Products Advisory Committee, also known as VRBPAC, and CDC's Advisory Committee on Immunization Practices, also known as ACIP. We also support the Medical Group Association's Rise to Immunize campaign, which has a goal to administer 25 million vaccines by 2025. Lastly, we also partner and actively contribute to the coordination and content included within the National Adult Influenza and Immunization Summit, which is co-sponsored by IAC and CDC. And that concludes my presentation. I want to thank you for allowing me to share all the work we're doing within OIDP.
Thank you, Mr. Dade. I do have a question for you. Just what community was targeted by those 2 grants? Was it in a city or a particular population in many cities? If you could answer that for me, please.
So for the Promoting Vaccine Confidence Grant, we had six cities that we targeted, so 6 organizations. I'm trying to tell you offhand. I know I think Minnesota was one. I know I'm gonna go with states. Minnesota, I know Oklahoma, North Carolina, Washington, and I can't, those are the ones I can think off the top of my head. And then as far as the OBGYN grant, that was based on data that we received that they were using. I know they were targeting metro areas, I think 14 metro areas. I know Texas was one of them, but it was more specific to those areas with low vaccination rates.
Thank you. I appreciate that. Are there any other questions?
This is Tim Thielen. I have one. Is there any data available that you're working with or that you know of around whether the trend in confidence about vaccines generally is going up or down, and more specifically in particular populations?
I know the Kiger Foundation has some data, but the goal is with this project, so what we were asking so our 6 awardees to do is to get a better understanding of the vaccine landscape within their community. So that's going to include doing assessment, a needs assessment on the community they serve. So this will be in the form of surveys, this will be in the serve of in-person interviews. And so we're going to capture that data from this project. So that's one of the benefits of this cooperative agreement. So I'm glad you noted that, because you're right. I think the data out there, it's there, but I think there needs to be more data on this topic. So I think hopefully through this grant, we can acquire that.
It does seem like confidence is decreasing, so I think your work is timely. One of the theories for why the confidence seems to be decreasing generally is in reaction to mandates for vaccines in general. Do you find that any of the data that you're looking at supports that inference?
I haven't looked at data in specific to that topic, but I think when we rolled out this project, vaccine mandates wasn't even in play at the time. So I think as we go through the project period, that is definitely something we can maybe add into the survey and kind of ask our awardees to look at and see if mandates has either decreased or, the decreased vaccine confidence, because that, you're right, is a possibility that it has. So that's something of interest that we want to look at as well.
Thanks so much. Appreciate it.
Thank you.
Are there any other questions for Sean?
Thank you. Tamara, I'm having a problem unmuting, but I know we're getting ready for your selecting the ACCV chair, but I would like to make a motion with the commissioners that we do new business before the public comment, because when we voted last meeting, there was to be a discussion of my vaxxed, unvaxxed, and it has not been added to the agenda, which means that it goes after the public comment. But I'd like to make a motion that the commissioners vote if we could move this, the new business before public comment. Can we vote on that, or do we have to vote on that?
Can we just continue as the agenda has?
Well, the problem with that is that the public comments come before my presentation. So I'd like my presentation to be able to receive public comments. That's my concern. And I should be on the agenda, but I'm not, and that was voted on in the last meeting. So I would like to just have the public comments after my presentation. Do we need to vote, or can we do that?
So this is Dana. My question is, have we always done the public comment and then the future agenda new business after? If that's the case, I would say that we should continue it as that.
I agree.
Is there anyone else we have 6 members now, right? So can the other 4 members vote, please?
Well, this is Dan Boyle. Is there a process for this?
That's
change?
what I'm asking Ms.
The
Over.
question.
Yes, and I am, give me a minute. Let's see. So you all can take a vote on it. And usually it's someone, basically Karen is in this situation is saying that she wants to bring it up for a vote. Someone seconds it. If no one seconds it, then it's not brought up for a vote. So someone has to second it, and then the members can vote of whether or not you want to rearrange the agenda.
So as I understand the motion, Ms. Kane, this is Tim Thielen, is for movement of the agenda of the new business to come before the public comment session. Is that right?
Yes,
I second that motion.
thank you.
So now you all take a vote, and you all could call out either if you agree or no.
Tim Thielen, no.
Dan Boyle, I agree.
AZ Holloway, no.
Dana DeShawn, no.
Bill Spiegel, no.
Okay. Then let's carry on to
Public comment now.
well, I thought we just agreed not to do it. I'm confused.
No, because you wanted to have
Oh, the
future
public comment.
business code before the public comment, and they agreed the public comment is now, and then you can go and have and discuss future business. That's
Well,
what the vote was.
I understand that, but I thought that the ACCV chair selecting was before the public comment.
No, if you look at the latest agenda, the one is December 1, that's in the meeting book. It's basically the public comment period, future agenda items, then selecting the chair, then adjournment.
Okay.
So right now it's public comment.
Okay, welcome public comments. Thank you.
Okay, if you'd like to make a public comment and you are online, you can raise your hand and we can unmute you. If you are on the telephone, please press *9 and we'll be notified to unmute you.
How do I raise my hand? I'm sorry.
We can hear you now.
Okay, hi, this is Aaron Siri. We submitted a public comment on behalf of ICANN, the Informed Consent Action Network. I don't know how to raise my hand, so I apologize. But should I make my public comment now?
Yes, please.
Okay, great, thank you. So I heard somebody talking just a bit ago about vaccine hesitancy. And I think that, you know, in a component with relation to vaccine hesitancy, at least one that we hear all the time is that, and it relates to the studies, the clinical trials that are relied upon to license childhood vaccines, and then the post-licensure safety studies and systems that are in place to assess safety for childhood vaccines. And I think that one of the important components, and ICANN believes one of the important components of assuring increasing vaccine confidence is to increase the safety profile of the literature and systems that are in place for assuring the safety of the childhood vaccination schedule. Certainly, we all care about children who are, could be harmed by diseases that vaccines are intended to prevent, and we should obviously have the same care and concern for children that might be injured by the intervention. The vaccinations intended to achieve that result. Prior to licensure, as many of you may be aware, may not be aware, most childhood vaccines are the clinical trials conducted to license almost all childhood vaccines do not really assess the safety profile of each childhood vaccines. They don't and they can't do that because one, most of those clinical trials were underpowered. They included typically a few hundred to a few thousand at most children. Two, they virtually never had a control group that received a placebo, and in many instances didn't have a control group at all. And when they did have a control group, it would either receive a different vaccine, which itself was never licensed based on a placebo-controlled trial, or some component of the vaccine, such as with Gardasil, they received the aluminum adjuvant, and the other components of the vaccine just minus the antigenic content. But there is no separate study that shows what is the safety profile of just receiving that injection. And so prior and every package insert as required by federal regulations in section 6.1 summarizes the clinical trials that were relied upon to license each childhood vaccines. And you can go in there and see for yourself. Everybody can, right there on the FDA website, you can confirm what I just described. On the FDA website, and for each licensed vaccine is also typically a summary memorandum prepared by the FDA that also summarizes, not always, but many of them have a summary memo that summarizes the clinical trials that were relied upon the licensed product. And you can find, by simple cursory review, that they were pretty much all underpowered, didn't have a control, and the safety. And the final component is that the safety review period was typically either a few days or a few weeks for almost all of them. For example, if you look at Recombavax HB, which is the one of only 2 standalone hepatitis B vaccines given to babies on one day of life, birth, it was licensed based on a clinical trial for children that included about 100.
Mr. Siri, this is Tamara Overby, and so you're approaching a 5-minute mark. So can you wrap up your comments so that we have time to allow others to speak too?
Absolutely.
Okay, thank you.
Thank you for that warning. And so for that one, it had about 150 children. It reviewed safety for about 5 days, and it had no control group. And that's been confirmed by the actual reports produced by the FDA, the actual reports that were filed to license the product. So pre-licensure, you don't know. And then after licensure, there are the safety systems, VAERS. You all know the problems with VAERS, right? There's VSD, which are really just, it's not an active surveillance system. It's just individualized studies often done to confirm existing policy. And then there's BEST, which is similar issues as VSD in that regard. And then, a lot of folks say, well, let's just look around. Kids seem to be fine. But when you do look around, in the last 30 years, there's been a tripling of all kinds of chronic health issues. Children often immune-mediated, atopic, immune-mediated neurological disorders. And it doesn't mean that vaccines cause those issues, but it certainly means that we should rule that out. And those studies have not been done. One of the important core missions of ACCV.
So, Mr. Siri, your 5 minutes are up.
Can I just get 15 seconds?
I'd like to,
Yes.
I'd like
Yes,
to make a
15
motion
seconds. Mhm.
to extend his time by 30 seconds.
Okay. Sure.
Yeah. Oh, thank you. So I was gonna say that the ACCV charter says, one of the things that quote is to advise the secretary on means to obtain, compile, publish, and use credible data related to the frequency and severity of adverse reactions associated with childhood vaccines. And quote, I think that part of that, I think getting more of that data is critical, not only to ensure safety, but also reduce hesitancy. And I hope the committee takes a moment to read the letter that we have submitted in that regard. Thank you very much.
Thank you. Are there any other public comments?
There are. We have one unmuting now. Just a moment.
Hi, can everyone hear me?
Yes.
Thank you. This is Teresa Wrangham with the National Vaccine Information Center. Thank you for the opportunity to provide a public comment. I wanted to thank the Commission today for more discussion on the vaccine safety data link. In response to comments with regard to 13 studies looking at safety, I guess from our perspective over time and looking at vaccine safety of 40 years, I'm just wondering, I encourage that the VSD be more publicly available to independent researchers and have certain studies been replicatable. That's the gold standard when we look at research is, are findings reproducible and are they being reproduced in a way broader acceptance? And that leads me to my second comment with regard to the vaccination plan coming out of MVAC and the hesitancy report they're going to issue, there's been an increase in not using stakeholders from the very population that you're trying to convince to use vaccines. More specifically, the hesitancy confidence report coming out of MVAC has no stakeholders from that arena. If you seek to convince people of the safety of vaccines, particularly the hesitant, you're going to have to bring them to the table and address their legitimate concerns around safety, which have been mentioned by Dr. Salmon within MVAC several times, and certainly highlighted by the Institute of Medicine. So I would encourage more transparency in that respect. And to my opening comment, when we discuss VAERS and other things in place to look at potential safety signals, I'm wondering if VSafe data is going to be integrated in a higher level of transparency and understanding of potential signals, has access to that as well. Which was part of the point of the. I'd like to Sherry for regard to how it can be done. So I think the new
Teresa, this is Tamara. You're breaking up, so we're not hearing everything that you're saying.
I think Ms. Overby, I can submit it, but I just want to thank the commission. I encourage more transparency and with regard to data and replication of VSD findings outside of industry and agencies, and appreciate the conversations today. And I'll leave it there. Thank you.
Thank you. So Amber, next comment, if there are any further public comment.
There are. We're unmuting the next one.
Okay.
Hello, my name is Carolyn Gamicia. I'm on this meeting. I actually found it by accident, but I just wanted to give you a little background. Our son is vaccine injured. I'm a parent of a now 30-year-old adult that has vaccine injury. I also was vaccine injured as a first responder from the Hep B series. And I wanted to, the reason that I'm here today is that I have concerns regarding the ACCV and the vacancies that currently take place, that are currently present regarding your vacancies for another parent to be representative on the commission, as well as an attorney that would be representing individuals that have been injured. Because it's a great concern of ours, our son did not have a recourse within the liability standards that had been established. And I think it's very important for this commission to realize that something as simple, and I'd like to applaud Ms. Kane. I've listened to this meeting and she's asking some very significant and important questions that a lot of us as families that have been affected adversely without recourse have concern about going forward with vaccine safety in this country. I'd also would like to express concerns regarding the public comment that I'm currently giving. I would like to hear the entire meeting prior than providing comment. I don't understand why this commission voted against allowing Ms. Kane to have her item that was supposed to be on the agenda even be considered for public comment. Every other government commission meeting that I've attended, public comment is weighted to the last section. I've already expressed concern regarding the limited time frame, 5 minutes on the opening comment on the agenda items. If I would have known more about that, maybe I would have commented on that as well. My concerns regarding this commission is that currently it is not functioning the way that it was designed to do so within the legislation that was written to establish it. I do have concerns that there is not a task force on vaccine safety that you could collaborate with to discuss what you would be currently suggesting to the secretary to be looked at regarding research. For someone like my family, I have concerns regarding predisposition for vaccine injury, which my son and I both have a genetic predisposition for that. We're not discussing that within vaccine safety. What this commission is discussing is a lot about administration of vaccines. And we have a country now where we have 54% of children in this country are chronically ill. That has been proven, and we have children that could be more predetermined to be injured by vaccine, and we're not looking at that. One of the things that I also have concern about within litigation and providing due process for families to go through the VICAP is that we currently really do not have vaccinated versus unvaccinated studies that can be utilized within these court proceedings. My concern too now is that we have a COVID-19 vaccine initiative for children in this country that is moving forward without any liability and without any studies on vaccinated versus unvaccinated within a population that has a very small percentage rate of even contracting COVID-19. And please know too that I am well aware that there are children in ICUs because my son has to go, my son that is vaccine injured, his medical bills last year were $1 million. He goes every month for IVIG treatment because his immune system does not have natural immunity and his antibodies are attacking itself. That was caused by a vaccine injury. So he is a single child or adult now that I will never have to worry about grandchildren being subjected to vaccine injury because he will never have a child. So I'm here because I want you all to know that I will be watching these proceedings, and I will encourage other parents to do so, because even parents of children who aren't vaccine injured should be concerned about the safety of vaccines and what the ACCV is doing regarding research recommendations to move forward to ensure not only safety, but effectiveness, and then what can be done to ensure that a person has due process within the liability standard. I am not a doctor. I am not a medical professional like the people that have presented here. And I did learn much today regarding what is transpiring within our federal agencies. But I want you to know, I want you all to know that even just attending this meeting is very difficult for somebody that has a child that has been subjected to a vaccine schedule that damaged him and will probably shorten his life. And I want you all to know that what you're doing and what you're moving forward within the purpose of this commission is very important to have representation in those currently vacant seats. Because if you even voted something as simple as not allowing Ms. Kane to present her presentation prior to having public comment, that's a problem for somebody that she's representing our families. I think that that should have been considered. It wouldn't have done anything for your meeting to do that. And she should be respected in the position she's currently holding. I don't have any further comments other than to request that this commission form some type of a task force or committee to actually look at what I've already discussed. Predisposition to vaccine injury, unvaccinated versus vaccinated studies, and also ensuring that people have the information when they do vaccinate their children regarding informed consent, because that's currently not transpiring. I do appreciate your time today, and I appreciate the dedication of this commission because it's very important, but I also want to ensure that you all know that there's families like mine who have a 24/7 responsibility to take care of a young man with a disability that resulted from a vaccine injury. So thank you very much.
Thanks for your comments. Amber,
have
are
another-
there
Yep,
any
we
other
have another-
comments? Okay.
Yep, we have another public comment.
Hi, everybody. This is Jim Moody in Washington. I'm a director of National Autism Association and a lawyer with the Petitioners Bar Association. And I would like to thank you for the meeting today, and thank you for the opportunity to present comment. It was a very interesting meeting. I would like to strongly endorse the public availability of the vaccine safety data link, both for the Petitioners Bar and for outside experts. I quickly looked at the 13 studies my friend at the CDC listed, and it looked like they were all done as internal studies, either from CDC researchers or those affiliated with the member HMOs. The one study he did mention illustrates the point. It was the less vaccinated children had fewer encounters, which is consistent with many of the 56 studies that are in the sort of the bucket of vax versus unvax studies that are available on the Children's Health Defense website. That less vaccinated children have, this is maybe an unfair summary, but better health outcomes than vaccinated children. It would certainly help to have access to VSD to be able to do rigorous studies in an official government-sponsored, taxpayer-funded database. I was somewhat surprised that my friend at CDC mentioned that the VSD is not a research database and the data is not collected for research purposes, since throughout all of the federal government's vaccine safety literature, including the vaccine safety system paper put out by NVAC, VSD is highlighted as the gold standard for government vaccine safety research. I believe it's the case that all the families asked to participate sign research consents when they sign up with those HMOs. So if they're not treating that as a research quality database, then we've got to kind of start from scratch here and have a research quality database. Certainly it can contain claims data and should contain claims data as well as EMR, but it certainly should be looked at as a research quality database and maintained with the necessary controls that it is usable for research purposes. It's particularly important to be able to compare vaccinated to unvaccinated children as a group rather than looking at particular pre-specified health outcomes or partially vaccinated children, both for reasons of statistical power and because in any good epidemiology study, we need to have completely unexposed rather than partially exposed controls. It's just going to add noise to the data. I'm happy to know there's 1% of the children in there that aren't vaccinated, and that would certainly be enough to give statistical power if there's about 9 million kids in there overall. The government has access to VSD, as do its experts, but the petitioners do not. And that makes it, since it's raw data and de-identified data, it's customary that both sides in litigation, and this indeed is quite adversarial litigation despite congressional intent, have access to the same raw data. So it creates a tremendous problem of unfairness that the petitioners don't have access. We've tried a few times to get access from the special masters, but DOJ has vigorously opposed access at every opportunity. And as people in the commission are aware, transparency and accountability are absolutely essential to preserve confidence in the program. IOM has harangued the injury program for 2 decades now, starting back in 1996, that vaccine safety data ought to all be public so that everybody's experts can have at it. And this is a persistent problem. This lasted now for 2 decades, so I think it's very, very important that ACCV is starting to focus on this and will take steps necessary to make VSD fully public and fully available as raw data and let the experts have it out rather than shroud VSD in a cloak of secrecy. I got interested in this way back in 2000 when Dr. Verstraeten at CDC did the original study using VSD to look at mercury, and he found a 7.62 relative risk for autism caused by early exposure to mercury in the vaccines. This is before it was taken out of most of the vaccines. He then, after meeting with the pharmaceutical representatives, took out all the unvaccinated children out of that study. This is post-protocol, which again is a problem. And then that erased the signal. So by the time we got to the actual litigation of these mercury cases in 2005 through 7, that signal had been erased from his original finding. And that's what kind of got me interested, that we really need to have public access to this VSD data to drill down and let the experts fight it out, but not hide it in a cloak of secrecy. So I would urge ACCV to take the necessary steps to understand how VSD and other potential databases such as Optum or Medicaid data or other claims data can be used to make the program work better. Congress intended that every injured child be compensated, and as relevant here, that ACCV take steps to reduce the number of adverse events. You can't reduce them if you don't know what they are and how many there are, and that's why this repeated discussion and availability of VSD is so important. Thank you so very much. Appreciate the opportunity to make public comment.
Thank you for your comment. We have another public comment.
Good afternoon, everybody. My name is Mike Milmo. I have been a vaccine practitioner for about 35 years, the first 30 years with the government as an attorney at the Department of Justice, representing the government's interests in the vaccine program. And when I retired in 2017, I now represent individual petitioners in the vaccine program. I've just got two really quick comments that I'll make. The first is, I think this is just an administrative error, but I think the presentations and especially the slides are very important to making the record of these meetings. And I just noticed that the DICP presentation is not listed in the things that are publicly available for today's meeting, and nor has the DICP presentation been added to the last two meetings. And I think the slides are really important to sort of create a record as to what's happening. And I would just ask Tamara, if possible, to add your presentation from today, which I thought was very helpful, to the website, and to go back and add the ones from the previous two meetings as well. My second comment is just also very brief, and that is that there was a discussion today about the coronavirus vaccine. I think the issue was raised about, when, if ever, will that vaccine be added to the VICP? And Tamara said that it's up to Congress to impose the excise tax, and that HHS can't lobby Congress, and I understand that. But I am curious, and I think it would be helpful if Tamara or someone else from the program could explain to us what has happened in the past. Obviously, when the act was passed in 1986, there were only a handful of vaccines. Dozens of new vaccines have been added over the years. Influenza in 2005, that's the big one, since that encompasses most of the litigation these days, but lots of other vaccines, rotavirus vaccines, hepatitis vaccines, HPV vaccines. And I think it would be helpful if we could get the historical perspective as what has HHS done in the past to work with Congress, if anything at all, to make sure that Congress knows that it's time to impose the excise tax. Seems like for all of the other vaccines, it's been sort of automatic that Congress just did it. But if HHS has played a role in the past of coordinating with Congress to let them know that the time has come to impose the excise tax, I think that historical information would be very helpful, because it sounds that with the coronavirus vaccine, it sounds as if the HHS is taking more of a hands-off approach. And if that's the case, I think it would be helpful to know why. And so just some historical background on what's been done in the past when all of these other dozens of vaccines have been added, I think would be very, very helpful for the public to know. Thank you very much.
Are there any other comments? Amber, are there any other comments?
We do have one more public comment.
Okay.
Okay, hello. I would just like to, first of all, bring your attention to my profile picture for Zoom. It's a basic agenda setup for any meeting where comments follow all business, whether new or on the agenda. And I don't think it's proper that you're not allowing comments for Ms. Kane's presentation. And the other thing I want to ask about is there a vetting process for members on this committee that would look into portfolios to see if they have any investments or conflicts of interest that might affect their judgment? That's all. Thank you.
Any other comments,
Hi.
Amber?
Yeah, we have one more public comment.
Hi, this is Teresa Wrangham again with the National Vaccine Information Center. I'm in a better location and was hoping to clarify my comment. Is that possible?
So Teresa, you said that you were going to send them in writing, right?
I can, but if you still have time, I'd rather just do it if I could summarize online
Sure.
while the commissioners are on. Thank you. I appreciate that. Basically, what I was saying is I appreciate the discussion today on VSD. I would agree with Mr. Moody with regard to the research setup of VSD. We need higher transparency. The reports that come out of VSD are being used to tell the public that vaccines are safe. Are the 13 studies that CDC refers to, for instance, replicated? And that's the gold standard of anything, is that when a research is put out, it's replicated to reconfirm those findings. So I would encourage that the VSD be opened. I also think that Ms. Kane's question with regard to access, who's had access outside of, agencies and so on to the VSD? Are independent researchers being allowed access? My other comment was with regard to vaccine hesitancy and reports being issued out of the National Vaccine Advisory Committee. Stakeholders are not being pulled in from the hesitancy population, and yet reports are going to be issued recommending how best to convince this population of the need to vaccinate. Again, a higher level of transparency and independent research, and treating them as stakeholders in their own destinies would be highly recommended. I appreciate Mr. Siri's comments with regard to the need for using placebos in trials so that signals are not dampened. So with that, I'll just thank the Commission for their discussion today. I hope that we hear more about the task force that should be consulting with the ACCV and why we haven't had a report since 1998. Thank you very much.
There's no more public comments.
Okay, should we move on to the vote of chair with Tamara Overby, Ms. Overby?
Karen, the next item on here is future agenda items and new business. And so this was your opportunity to speak.
Okay, fantastic. I don't know why I opened up today's, but mine's different. But anyways, here we go. Okay, thank you for this opportunity. I want to speak briefly about the need to establish a work group on the use of epidemiology in the program with an emphasis on CDC's vaccine safety data link. The ACCV is a very unique commission. Congress has put us in charge to represent the children and given us oversight responsibility to the program. Congress established 2 relevant goals for the program. 1, to compensate the children who are injured by vaccines swiftly, fairly, and generously under a standard of proof, given the general state of ignorance about how and how often vaccines can and do cause injury, where doubts are resolved in favor of compensation. Reasonable doubts about causality should favor the injured child who has taken a hit for the team, for the greater good. Number 2, making the childhood schedule safer. In Section 27, Mandate for Safer Childhood Vaccines, Congress directed the Secretary to promote the development of childhood vaccines that result in fewer and less serious adverse event reactions than those vaccines on the market on December 22, and use his various powers, including research and adverse events reporting, in order to reduce the risk of adverse events to vaccines. Congress tasked ACCV under Section 19 of the Act with the purposes of relevant of 1, advise the Secretary in implementation of the program, 2, advise the Secretary in implementing the Secretary's responsibilities under Section 300 AA-27 of this title, mandate for safer childhood vaccines regarding the need for childhood vaccination products that result in fewer or no significant adverse reactions. Number 3, on its own initiative or as a result of the filing of a petition, recommended changes in the vaccine injury table. Number 4, advise the Secretary on means to obtain, compile, publish, and use credible data relating to the frequency and severity of adverse reactions associated with childhood vaccines. And number 5, recommend to the Director of the National Vaccine Program research related to vaccine injuries, which should be conducted to carry out this part. Thus, the availability of high quality data comparing the health outcomes of children vaccinated per the CDC schedule to health outcomes of unvaccinated children, i.e. controls, is a core mission of ACCV's oversight responsibility. This metric will facilitate compensation of all those injured, as well as the goal of reducing adverse events per the congressional mandate. Transparency and accountability from the use of these data will contribute to the establishment and maintenance of public trust, so necessary for a workable public health program, such as a mass vaccination of children. As a shorthand or nickname, I will refer to this as a vax versus unvax data. My position on the ACCV board is as a parent who has a daughter who was injured and compensated for her injury. Of course, because my daughter was injured and died from her vaccine, my focus is to make sure the best interest of the children is carried out. This commission should have 9 different positions filled. There should be another parent position. This position has not been filled for 2 years. I have been on the board. Each commissioner should be bringing their expertise to the table, none more important than the other. Conversations about vaccine safety should be open on the public record and encouraged. Because the studies I have suggested since December 2020 to discuss with the commission have been rejected by Ms. Overby, not on their merits, but for being published in low quality journals, I will be discussing with you today 3 papers, reports that have been done and paid for by HHS, CDC, i.e. the taxpayer. These reports, as you will see, support my stance in carrying out ACCV's and the program's core missions and in suggesting to Secretary Becerra future research. Open conversation is needed rather than the council culture to comply with Congress's wishes to continue research to enhance stakeholder confidence and close the gap in vaccine safety. If the vax-unvax studies done to date can be improved or published in better journals, then this is all the more reason for frank discussion and improvement. If Tamara won't permit this discussion by the commission, then it is additional reason to refer to the matter of the use of epidemiological evidence in the program to a work group for a full discussion and analysis. report, and recommendation. Unlike most adversary committees, it must be noted that families of injured children in HHS and its staff are actually adverse parties in litigation, and this may explain some of the desire for the secrecy and inaction. But such lack of transparency and accountability is simply unacceptable, given the goals assigned by Congress to ACCV and the program. I will start with IOM's Vaccine Safety Data, Access and Public Trust study from 2005. This paper is all about the VSD. IOM's review was conducted in part in response to the controversy associated with deleting unvaccinated children and other post-protocol data manipulations, discovered thanks to FOIA in the Verstraeten paper. Without going into too much detail here, Verstraeten and colleagues originally found in 1999 from a study of mercury exposing using VSD that children exposed to the full load of mercury during the first few months of vaccination were 7.62 times more likely to eventually receive an ASD diagnosis. The VSD was created to close the gaps and limitations in vaccine safety. The VSD is a large linked database that was created in 1991 to fill a void in the ability of the United States to study vaccine safety issues and to enhance public trust. The VSD should be used as a tool to address specific concerns about vaccine safety. In the first paragraph of the abstract, it tells us that the VSD can be a valuable tool for the retrospective assessment of vaccine safety. Following a secret meeting with pharma representatives and public health officials, but no parents, petitioners, counsel, or public representatives present, the unvaccinated children were deleted from the study to hide this crucial safety signal. As worst, these post-protocol deletions of study subjects with the intent to alter the study's findings was science fraud. At best, it revealed weakness in VSD that should have been correct during the design phase. To state the obvious, it borders on absurd to have a medical records-based vaccine safety database without an adequate number of unexposed controls. Such controls would be unvaccinated children based upon self-selected non-medical exemptions. The Justice Department went on to vigorously oppose petitioners' access to VSD in the Mercury Autism Omnibus proceeding. It is manifestly unfair and contrary to the congressional purpose to permit one side, the defense, and its experts to have access to raw data while at the same time barring petitioners' access. Returning to the IOM Public Trust and Data Access Report, the paper had three goals. One, to facilitate access to and use of the VSD. Number two, to protect the confidentiality and individually identifiable data in the VSD. And three, to enhance public trust in the VSD as a tool to address specific concerns about vaccine safety. On the basis of those three goals, the IOM committee developed its recommendations related to the VSD data sharing program in the following framework. The NIP should support the broadest feasible use of the VSD for vaccine safety research within the constraints of the law, protection of confidentiality, and the VSD contract provisions. Bureaucratic and technical barriers to accessing the VSD should be minimized, although some types of studies may require collaboration with or facilitation by data custodians. Guidelines for proposals from independent external researchers should be developed and publicized to facilitate access. Responses to proposals should be timely. Criteria for the independent review of proposals should be publicly accessible. It is unknown whether CDC's data sharing program has worked either for petitioners or independent researchers in any meaningful way and may contain undue barriers to access. Moving on to the CDC white paper from 2015. It was paid for by the CDC and recommended by the IOM. The Institute of Medicine in 2012 convened a committee to gather stakeholder input and scientific evidence on the safety of recommended childhood immunization schedule using various studies that had already been made. Numerous times in the white paper, it is suggested that further research is warranted regarding vaccine safety. The white paper states specifically that doing a vaxxed versus unvaxxed study with alternative schedules needs to be done to ease the concern of the stakeholders. It also states in numerous places to use the VSD to do the study. Under recommendation 6-2 in the white paper, it states that the VSD is a useful collaborative project for conducting both post-marketing surveillance and longer-term targeted research. Then it goes on to say that the VSD is currently the best available system and most feasible for studying the safety of the immunization schedule in the United States. Recommendation 6.3 of the white paper recommends that HHS funds and supports the VSD project. The white paper specifically tells us, 1, to review scientific findings and identify stakeholder concerns related to the recommended childhood immunization schedule. 2, identify research approaches and study design to understand weaknesses and financial feasibility. It states that few studies have focused on elements of recommended childhood immunization schedule as a whole. The lack of conclusive evidence linking adverse events to multiple immunizations or other schedule exposures suggests that the recommended schedule is safe. Concerns from stakeholders merit exploration. The committee concludes that data from existing surveillance systems, such as the VSD, could be used and offer the best means for ongoing research efforts regarding the safety of the schedule. In recognition of this, future federal research approaches should collect and assess evidence regarding public confidence and concerns about the entire immunization schedule. The study goes on to say that vaccines rely on community immunity, which is waning, and encourages studies to be done to help ease the stakeholders' concerns. The White Paper Committee, NVPO of HHS, asked the IOM to convene a committee of experts to identify feasible study designs to explore the safety of childhood immunization schedule. The white paper states, despite the VSD limitations, it is currently the best available system for the study of the safety of the immunization schedule in the United States and holds tremendous promise for advancement, including the potential for future prospective cohort studies. The white paper in 2015 states that the funding for VSD has totaled approximately $9 million a year of taxpayers' money, with additional funding being provided for special projects, making VSD a relatively low-cost and effective data system for investigating immunization safety. How much of the taxpayer dollars goes to funding the VSD each year? Is my question. Why is this not being used to answer the stakeholders' questions of safety in the vaccine schedule? I move on to the IOM report of the childhood immunization schedule from 2013. This study tells us over and over again that the VSD could be valuable for answering the research questions. The study states that the most feasible approach to studying the safety of childhood immunization schedule is through analysis of data obtained by VSD. Under methodological approaches 119, fund and support VSD to project a safety study. It also suggests that more studies using the VSD be done. To date, no vaxxed versus unvaxxed study has been done using the VSD. Listed under the conclusions of the childhood immunization schedule, the committee's review confirmed that research on immunization safety has mostly developed around studies examining potential associations between individual vaccines and single outcomes. Few studies have attempted more global assessments of entire sequence of immunizations or variations in their overall immunization schedule and categories of health outcomes, and none has squarely examined the issue of health outcomes and stakeholder concerns in quite the way that the committee was asked to do in its statement of task. No one has compared entirely unimmunized populations with those fully immunized for the health outcomes of concern to stakeholders. As I quote from the childhood immunization schedule, the VSD is currently the best available system for studying the safety of immunization schedule in the United States. My reasons for this to be done, why I'm here today. The ACCV is in charge of program oversight. We have been tasked by Congress to question the bureaucrats who, legally speaking, are the adverse defendant in program cases. If we cannot question authority and fight for improvements that better serve the congressional goals and have conversations about vaccine safety, what is the point of the ACCV board? Congress wanted every injured child to be compensated swiftly and appropriately. If there were to be error, it should be on the compensation to the injured. Section 19 of the statute makes recommendation to reduce injuries. This is our purview. We can't reduce the injuries if we don't know how many there are. The only way to get the proper epidemiology is from doing a vaxxed and unvaxxed study. We should be doing this every 2 years. Congress told us in the 1986 Act to reduce the adverse events. The IOM has told us over and over in the 2006 report to improve public confidence. The 2012 report says that the gap has to be filled with information from a vax study. In 2015, the CDC proposed to do a study. Congress said to do this. We should do what Congress says. IOM has reinforced the idea of ignorance is not a substitute for science. We just don't know what the epidemiology is. It is our job to reduce adverse events. In my opinion, the ACCV is failing in our mission to reduce injuries, suggest studies, and have conversations that is related to our purview. The ACCV is 1 year behind during one of the most important times in history for vaccine safety. My question to the CDC is, what have we done since these reports? How to make childhood vaccine schedule safer is part of our purview when the petitioner cannot win off table cases without the proper epidemiology. That epidemiology comes from running vaccinated versus unvaccinated studies. The baseline is to first see how unsafe the vaccine program is. How do you make a car safer? It's how we make any product safer. How much death and injury there is. You look at that. That is part of the commissioner's responsibilities. It is our mission. Making recommendations to the secretary after researching in work groups is all part of our purview. I am suggesting, as the IOM has suggested numerous times, we look at the VSD. I encourage having a free and open conversation about the vax studies by numerous doctors and scientists. I agree that these studies need to be improved upon. All the more reason we need to utilize the VSD. Please explain to me why I cannot have this discussion. Please explain to me just why these studies cannot be discussed. The white paper and the rapid cycle analysis were done in real time, and the CDC prides itself on how fast they were done. Why can't the CDC do this for vax and vax study? Medicare is already using the VSD to do COVID epidemiology studies. Why can't we use it for vaccines? So I've emailed everybody my charge, but I will continue on to the stakeholder concerns. I know a lot of people have already spoken about stakeholder concerns, but here we go, and I'm almost done. The IOM has asked numerous times to fill the gap. Many changes have been made to the schedule since the studies that we've talked about today are old. The World Health Organization 2020 meeting stated that stakeholders and even doctors are showing concern. This is the first time doctors shared concern and shared their hesitancy regarding the vaccine program. Box 6.1 of the white paper has 4 primary research questions. 1, how do child health outcomes compare between those who receive no vaccinations and those who receive the full currently recommended immunization schedule? 2, how do child health outcomes compare between those who receive the full currently recommended immunization schedule, but who omit those who omit specific vaccines? Number 3, for children who receive the currently recommended immunization schedule, do short or long-term health outcomes differ for those who receive fewer immunizations per visit? And number 4, do potentially susceptible subpopulations, for example, children from families with a history of allergies or autoimmune diseases who may experience adverse health consequences in association with immunization with the currently recommended immunization schedule? The Vaccine Safety Research Data Access Study on page 39 states that the VSD can be used to respond to the public scrutiny and concerns regarding vaccine safety. The demand by consumers for more information about issues regarding child health is growing. That is evident by the public outcries. Consumers insist that there be more and more transparency with access to data and more studies. Trust can be enhanced only if public has confidence in the independence and fairness of the decision-making process for VSD research priorities and approval of VSD data sharing proposals. Finally, turning to the work group, a draft charter has been circulated to the Commission. The work group can have thorough and detailed discussions and prepare a report and recommendations for ACC and ultimately the Secretary. So again, I'm asking today that the commissioners vote on creating a work group to further research and look at vax and vax studies and other safety studies to be reported to the Secretary Becerra. And that is my presentation. Thank you.
So this is Tamara, and Karen has made a proposal. I can tell you one thing is that all these documents were just sent to members like yesterday or today. So I'm sure members have not had a chance to review anything. So I would think that that would be kind of challenging to vote on the issue and you haven't read background documents. But it's up to you all as commission members of whether or not you're ready to take a vote on this issue to form a work group, or if there's more time needed because you need to review documents, the documents that were sent. Also, the document that Karen sent earlier with her summary for the work group has some inaccuracies in it. And I conveyed that to Karen, but they're still existing in that document. Just so people are aware that she and I were communicating about this document, and I requested some things be fixed, but they weren't fixed. So it's up to the members at this point of how you all want to proceed, whether you want to vote on it or how do you want to proceed moving forward.
I'd like to add, with all due respect, we've been talking about this presentation, and originally my presentation was adamantly refused by you. So this isn't something that has just happened over the last couple of days. I sent you my charter on the 22nd, and my understanding is that the ACCV board was to support, I received an email yesterday saying that things needed to be made more clear. It wasn't specific that it was supposed to be made more clear by me because I did approve the information. So we're having the same old conversation again about me being at fault for not preparing information timely, but this has been an ongoing battle. And I think it reflects more so today that I am not on the agenda and I am in new business again, because this is where all my comments always end up in new business. But all I can do is keep doing my best, because that's why I'm on this board, to support the health and safety of children. So I would very much like to have a vote if we could create a work group. I think it takes 2 people to create a work group. And so that's my plea.
I think this is Dr. Holloway. I got most of your information, I think, last night. It's at least 50 pages long. I haven't had a chance to look at it. So, I can't make an intelligent decision. So I'll at least read through what you sent us.
Are there other comments by other members? And if you're talking, you may be muted because we don't hear anyone speaking at this point. So can you remember to unmute yourself?
Tamara, Daniel Boyle's trying to make a comment. I don't know how he got out of the.
And also, I think Bill Spiegel said he can't seem to unmute. So, yeah.
Okay.
This is Dana Deshawn. I guess, Karen, my question is, and this is my second meeting with the ACCV. It was the last meeting where we got a very large amount of information, which seems different than the amount of information that we got last night. So I guess I am more than happy to look at this and certainly hear your concerns with it, but it's a lot. I received it, I think, at 8:30 last night when I looked at it, and I have not been able to look at that. And my question would be, what is this work group? I mean, I just want to know what the intention is, that we're trying to put something together that we are going to recommending more transparency for the vaccine safety data link, or that we're recommending that we want a study for vaccinated versus unvaccinated children, which I think there's some ethical concerns with that.
I'm happy to answer. Well, this has been an ongoing issue because this conversation, I've not been allowed to have this conversation, which has been a challenge for me that obviously I'm not giving up on. The information that I wanted to send to you a month or so ago was denied. And so this has been an ongoing challenge for me to be able to get you information that's accurate. And so the only way that I could even have this discussion was to use the reports that were paid for by the CDC. So what I would like to do is have a work group, and a work group is something that we mostly don't really even talk about. And when I became a new member, I didn't understand what it was about, because the ACCV should be having work groups, and we're there to discuss certain items. So I'm asking that a work group would be with 2 people, and it's done on our own time. It's part of our purview for the ACCV. We can invite the CDC. We can invite members who have done vac studies. We can invite other people to have this discussion so we can all understand. It's very, I'm a parent of a vaccine injured child. And so I want to have a group of people so we can have doctors and scientists and people who are the professional, survey people, whatever they're called. James Lyons is a scientist who constantly does studies. And so he could tell us about the epidemiology. And so we can all look at that and be educated. And then we can make decisions on that education and go forward to recommending information to Secretary Becerra and what we would talk about as being a safe study. And so it has been discussed for years now, for 20 years, about doing a vax-done-vax study. But every time I talk about that, I'm ridiculed and told that I don't know what I'm talking about. But that's why I wanted to discuss. That's why I was presenting for so long, because so many papers have talked again and again. The answer is in epidemiology. And to get the epidemiology, we should be accessing the vaccine safety data link, which is paid for by the taxpayers. We pay millions of dollars to have this data that we can't access and we can't talk about. And, over and over, everyone is talking about the stakeholder, being concerned about safety of vaccines, all vaccines. And then now we're putting, the COVID vaccine, who knows where that's going to go on. So this is a conversation of logic, and it should be done with doctors and parents and scientists. And that's what the work group is for. It would be the people on the commission who agree to form a work group, and we can invite people in and we can have this discussion. I hope, does that answer your question?
I guess, yeah, I think so.
So this is Tamara. So the role of the commission is to send recommendations to the secretary. So what this work group would have to do, if a work group is formed, is that they will report back to the full commission, and the full commission votes about whether or not they want to send a recommendation to the secretary. So Karen is asking for a work group that will report back to this full work group, to the full ACCV, and the full ACCV votes on whether or not they support whatever recommendation this work group comes up with. And if they do support it, then a recommendation is sent to the secretary. Our commission does not conduct studies. We do not direct CDC or FDA or any other agencies to do anything. These would be simply recommendations that would go to the secretary if the full ACCV agrees to whatever this work group recommendation is that they will ultimately present to the full ACCV. So that's how it will work.
And this is Dr. Holloway. I hear what you're saying. Again, I still have not had a chance to read any of the documentation that you sent out. And when you're saying a work group of 2, and then you're saying we're going to be calling people in, how do we decide who we're going to call in and those kind of things? I think it's pretty much not clear in terms of what we're trying to do with this work group. And again, I think we need to be able to look at that documents that you sent out first.
Thank you so much. And yes, I sent out a charge what the work group would look like and what it would do. What I meant when I said 2 people, there needs to be at least 2 commissioners to make a work group. So I cannot make a work group without another commissioner on board. And again, this is why I keep talking about this over and over again, how important it is to have another member, a parent as a commissioner, and the petitioner, because, we should just be having fair conversations about all of this. And so once a work group is formed, we meet separately and we have these issues. And part of what we can do is invite people to come and talk to us, because I'm not a scientist, I'm not a doctor, I'm a lawyer, I'm the parent, but I have the experience going through the vaccine compensation program. And so that's why it's so important that this board is full, so we can all participate and bring our expertise together and make these decisions. And I am very happy to wait another 3 months and have this on the schedule so we can all talk about it, so public comments can be made about it. I'm happy to start a work group with one other person. And so that's where I'm at. I have been on this board 2 years. And this was one of the very first meetings I had asking this to be done. So this is taking 2 years to have this conversation. And you can see clearly how difficult it is for me to get the information out. I've been refused and denied to send this information out. So that's why all of this seems so difficult, and it's so much information. When I started as an ACCV commissioner, I took this position extremely seriously. My daughter died from vaccine injury. And so I read numerous reports because I'm a parent, I'm not a scientist, I'm not a doctor. So I spend hours and hours doing this. Every single report I've talked to you today, I've read twice. I've read many, many other reports. I talked to many people, doctors and lawyers, and of course the stakeholder. I'm friends with numerous people who are living with vaccine injury. So this is a huge responsibility, and it's a huge task, and I've taken it on. I'm doing my very best to create something that when I walk away from this board, I can be proud of us doing, and hopefully changing the way people are informed about vaccines, hopefully using the vaccine safety data link and having an independent person run studies so we can look at it and be confident that we're getting information and papers not from the CDC. This is all about the stakeholder confidence, and there is no more important time in history that people be confident and comply to, everyone. Most of the people on this board want everyone to get vaccinated. And I'm saying that we should be having these meetings and these discussions freely. And all the other boards, the commissioners for other groups, government groups, they all have work groups and they all have meetings and they invite people. So this isn't something new. This is very typical. It's just not been done. I've been part of I think 2 work groups in the last 2 years. I hope that answers your question.
Karen, Bill Spiegel here. I am, I fully support everything you're trying to do here and the other members. My only concern too is I just think I need a little more time to read all the materials provided before voting on the work group. But other than that, I think hopefully 3 months down the road, this is something that can happen.
Thank you. I appreciate that. Is there any commissioner that's on the board that would like to be part of a work group now? I'm happy to wait.
So Karen, the commission has a vote to want to put this work group in place before it can be formed. So they have to vote to have the work group in place.
So this is Tim Thielen. I support the work group actually, but I haven't had a chance, being new to the committee, and to consider the issue very much, and have not been able to read the materials either. So I'd like to move to put it on the agenda next meeting, and make sure that it's placed after the vote is placed after public comment, because I'm sensitive to the public comment today that we got, that people would have liked to have heard Ms. Kane's presentation before they commented. With that motion, I would support talking about it next time.
Is there a second for the motion that Tim put on the table?
Thank you. Can I second it?
Sure.
Thank you.
All those in favor?
Well, could we, excuse me, this is Dan Boyle. It's more of a clarification.
Okay.
That we referenced, I heard Karen, you referencing the draft charter, and at first I did review the materials that came last night, and that included reports from individuals, which I found very enlightening, and it humanized this discussion that we're having today. But I didn't see a draft of a charter in that, but then I realized that came out this morning. So the materials, the 50 pages or so that came out last night, did not include the draft work group charter. But I see now that it came this morning in a separate email. So I just wanted to make that point. And that are we now, the motion is to what?
The motion is to delay this conversation to the March meeting so that members have time to review the documents that have been sent in the last 2 days.
And that it be placed on the agenda
Yes.
at a time that's after public comment.
Well, she wants it before public comment, right? So
I'm asking for the agenda. I'm asking for the agenda to be arranged. Okay,
Right.
let's take it in two
Yes.
motions. Let's take it in two motions. The first motion is that it be deferred to the next meeting and placed on the agenda. I'll make that motion first.
So is there a second?
I'll second that, Holloway.
Okay. And all those in favor?
Aye.
I agree.
Aye. Spiegel.
Okay. Okay. All right. So that motion is passed. So this will be added to the agenda in March.
Second motion, and this may be more contentious, is to make a placement so that there is availability for public comment about the charter and about the proposal that Ms. Kane is making before the vote occur.
Okay.
I'm confused. I'm confused. You don't want people to be able to hear or speaking on the schedule? I mean, before, I'm confused because today I was denied to move new business because the agenda is always the same. And so I had to make a motion and I was denied that, which is fine. But now you want to move this agenda down below so people cannot comment on it? I'm confused.
No,
about that.
the other way around. I want to make
Okay.
sure that the discussion that you're having about the working group that occur and that there's public comment before the ACC votes, the commission votes about whether to form a working group. So we hear public comment
Oh, okay.
to advise us.
Okay, that's okay. Thank you. I appreciate that.
I second that motion, Spiegel.
Okay. So all of those in favor of that?
Aye.
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 Is there any opposition? Okay, so therefore we'll have the presentation, we'll hear from the public, and then the members will vote on this topic at the March meeting.
Fantastic. Thank you.
Okay.
Can I
Thank
ask a question? Is Robert's rules used for governance over this?
I will have to get back to you, Karen, about that.
Okay, thank you. Okay, fantastic. Thank you.
Okay.
So now do I have permission to ask to proceed with Ms. Overby about the voting on chair?
Yes, yes. So the next item on the agenda is selecting an ACCV chair. And so I will open this up to the floor of members that are interested in serving as the ACCV chair. You can let us know at this point. And then, so if someone's interested, they let us know, then someone will second the motion. And then there will be a vote.
Well, this is Karen Kane, to no surprise. I would like to be nominated for chair. I've been diligently working as a commissioner for 2 years. I feel like I have the experience and dedication to carry out the duties as appointed by Congress. So I'd like to put my name in.
I second that, Spiegel.
Thank you.
Is there anyone else that's interested in serving as a chair?
Yeah, this is Dina Deshawn. I actually would like to put my name in as well. I am new to the group, but I have a vast amount of experiences as a pediatric nurse practitioner working in a pediatric primary care office for over 23 years. I've invested a large amount of my time with immunizations and research, presented multiple information to parents in the community, given numerous presentations through the local, state, and national conferences on immunization topics, including immunization hesitancy. I'm also an advocate for vaccines for underprivileged children worldwide through Shot It Live. I've spoken on Facebook Live events, newspaper articles, and radio broadcasts on immunization topics. I'm currently the chair for Special Interest Group on Immunizations with the National Pediatric Nurse Practitioner Professional Organization, which has given me opportunities to review the vaccine information sheets and currently the childhood immunization schedule for next year. Personally, I'm also a mother of 5 boys, so I do have an investment that vaccines are safe, not only for my children and protect them, but also for the children that I care for in my everyday practice.
So is there a second for Dana Deshawn's motion to serve as a chair?
This is Dr. Holloway. I second.
Okay. So now we need to take a vote for either Karen or for Karen and Dana Deshawn. So all of those in favor of Karen, please let us know by indicating your name.
William Spiegel. In favor.
Tamara, do I vote for myself?
Sure. Mhm.
Okay, I'm voting for myself. Thank you.
Daniel Boyle,
Daniel, you're voting for Karen?
yes.
Okay. Anyone else? Okay, all of those in favor of Dana Deshawn?
AZ Holloway.
Tim Thielen.
Okay, so it's a tie. And we've never had this to happen before, so we're gonna have to figure this one out, and we have to talk to, we have to talk to our Office of General Counsel and others to figure out how this works. So,
Can I ask if either of the candidates would withdraw in light of the tie?
I'm sorry, what'd you say?
Will either of the candidates like to withdraw in light of the tie?
so we will, like I said, I will have to communicate and discuss this with, because we've never had this to happen. So we'll have to discuss this with regard to figuring out policies or procedures for dealing with this. Okay, so that is the end of the meeting. We appreciate everyone's time and commitment, and thank you very much.
Thank you,
Is there,
everybody.
is there a vote to adjourn?
Holloway, so moved.
Okay, second. Okay, thank you, everybody.
Thank you.
Thank you.
Bye-bye.